You're muted.
So good evening, everybody, and we are live. We can start.
Good evening, everyone. We all welcome you to the 6th Spine Weekend today. This Spine Weekend was spread over 3 weekends in last successive 3 weekends. First weekend was on lumbar spine, and we had very good faculty for that from national as well as international renowned stalwarts were there. Second weekend was all about cervical spine, and we had a lot of discussions about intricacies in cervical spine surgery. And this is the last weekend which we are having, and we have the world-renowned spine surgeons as well as the nationally and internationally renowned spine surgeons from India and abroad. Today's topic is mainly focusing on spinal deformity. As we all are aware of spinal deformity, and deformity is not only scoliosis. There are a lot of issues. We have scoliosis, kyphosis, high-grade spondylolisthesis, and we are trying to get some bits about all these deformities today with all these stalwarts. I am thankful to Pune Orthopaedic Society for giving us this opportunity for this academic program. At the same time, OrthoTV, Dr. Ashok Sham and his team for releasing this worldwide today. And I would like to thank our own Sanjiti Institute for this brilliant academic support for us. Me, myself, my colleague Ajay Kothari, Siddharth Iyer, Pramod Bilare, Vishal Rokde, and Dr. Sandeep Javle will be the co-conveners, along with Dr. Sajan Hegde and Dr. Abhay Nene, who will be the academic chair. Today, I would like to thank all the faculty from all over the world for this academic feast, and we would like to just brief about few of the faculties for today's symposium. We have the world-renowned Peter Newton, Dr. Peter Newton from San Diego. We all know Dr. Peter Newton was the immediate past president of Scoliosis Research Society. Dr. Peter Newton had more than 200 international publications in his kitty, and we all know that he is famous for deformity correction. And we have Dr. Peter Newton talking about the selective thoracic fusion and his views, how he selects the levels in spinal scoliosis. We welcome you, Dr. Newton, for today's Congress on spinal deformity. The next faculty we have is Professor Kai Lam, and we all know that he's internationally renowned spine surgeon from London Bridge Hospital, and who was instrumental in establishing the spinal unit at St. Guy's and Thomas Hospital in London. And he's trained a lot of fellows all over the world. He has got more than 100 publications in spine. He does a lot of work on spinal deformity and disc replacement, degenerative, and all spinal surgeries. We welcome you, Dr. Kai Lam, for today's show, and thank you for giving your prestigious time. The next speaker faculty we have is Dr. Suken Shah. We all know Dr. Suken is one of the renowned spinal surgeon, and he's chief of Division of Spine and Scoliosis Surgery at Alfred DuPont Hospital in Delaware, USA. And we are thankful, Suken, for giving us this great time for today's Spinal Deformity Symposium. We all are aware that Dr. Suken Shah is very much attached to India, and he keeps coming for many conferences. And recent time we see that every year almost he's visiting India for delivering his knowledge and sharing with us. Thank you for giving us your great time today, Suken. We move on to the next speaker faculty, Dr. Masato Tanaka. We all know Dr. Masato Tanaka is one of the true academicians. We know him, and we know him from AO Spine. We know him from many academic meetings all over the world. He's the vice president and director of Oklahoma Hospital in Japan, and he has got fellowship programs. He's known for deformity correction, degenerative spine, at the same time cervical spine. We welcome you, Dr. Masato, for today's spinal webinar, and he will be starting his talk on high-grade spondylolisthesis. And we have the last international faculty, Dr. Ajaya Joshi. We all know Dr. Ajaya as the man behind Vector, who worked for deformity correction with Dr. Campbell, and he has publications on it. And he's doing a lot of work in degenerative spine as well as deformity. Today, Dr. Ajay Joshi from San Antonio, Texas, will be talking about the adult degenerative deformity for us. At the same time, I would like to thank all the Indian senior faculty for today's webinar and giving great time. We have Dr. Shankaracharya from Sant Gangaram Hospital. We all know Dr. Shankaracharya as a true academician and surgeons of India, and we welcome you, Dr. Acharya, for today's webinar. Dr. Acharya will be talking on angst and spinal deformity today, which is a very, very important topic, and all these cases comes to our practice, even if you are spine surgeons, neurosurgeons, or orthopedic surgeons, and it's sometimes a dilemma, how do we approach, and all these intricacies will be dealt by Dr. Acharya today. We have our next speaker faculty, one of the most important stalwart in spine surgery India has ever seen is Dr. K.V. Menon, and we all know Dr. K.V. as K.V. Sir, who has started the scoliosis week way back, almost 14-15 years back in India, and now in Pune we are doing the scoliosis week along with KV Sir and Dr. Abhay Nene for last 3 consecutive years. KV Sir is known for his work in degenerative spine, spondylolisthesis, as well as scoliosis. And today we'll be taking the pearls and tips from Dr. KV Menon for today's spinal deformity workshop. We welcome you, KV Sir. KV Sir is attached to Bharati Hospital in Pune city. Our next speaker is none other than one of the most significant contributor in Mumbai spine surgery team, Dr. Samir Dalvi. Dr. Samir Dalvi is one of the eminent spine surgeons from Mumbai. He's practicing for nearly 20 years in Mumbai, and he's practicing at Hinduja Hospital. Dr. Dalvi is known for his academics, he's known for his research, and he's known for his truly important tips and tricks giving to all the residents and fellows. We welcome you, Dr. Samir, for today's webinar, and we look forward for your talk on spinal osteotomies. As we know, Dr. Samir Dalvi extensively talks about deformity correction in various conferences. Today, he's very specific, and he's going to talk on the spinal osteotomies for deformity correction. We have our next speaker, Dr. VSP Rao or Dr. Surya Prakash Rao. We all know Dr. Surya Prakash is one of the renowned spine surgeon from India. He's practicing at Medicover Hospital. Dr. Surya Prakash Rao was famously known as a scoliosis guy from Hyderabad, as he was there in Nizam's Institute for nearly 14-15 years, and now he's at Medicover Hospital. His spectrum of practice is extensively complex cases, deformities, and high-grade listhesis. We welcome you, Dr. Rao, for today's spinal deformity session. Our next speaker is Dr. Vishal Peshettiwar. We all know Dr. Vishal as a MIS guy from Mumbai. Dr. Vishal is practicing as a head of the unit in Kokilaben Ambani Hospital, Mumbai. And he's got extensive work and one of the largest series in the world about MIS deformity correction, about high-grade spondylolisthesis. And Dr. Vishal will be sharing his tips and tricks about high-grade today with MIS approach. Our next speaker faculty is Dr. Bhauk Garg. We all know Dr. Bhauk as one of the true academician and a man who is doing extensive research work, publications from the All India Institute of Medical Sciences, one of the most prestigious institute in India and around region. We welcome you, Dr. Bhauk, for today's webinar, and Bhauk will be talking about the congenital scoliosis. As we all know, North India and all India, we have a lot of congenital scoliosis, and at times they can be very tricky. Congenital scoliosis can be really different than what we talk about AIS and other deformities. So congenital can be tricky, and we'll take some tips from Bhauk Garg. We have Sajan Hegde sir. We all know Dr. Hegde as one of the robotic guys from India, and he is the academic chair along with Dr. Abhay Nene for today, and he'll be talking about anterior reconstruction for scoliosis. And this is, they say this is a fading art nowadays. We are talking, and when we talk, myself, Dr. KV Ajay Kotari, and Abhay, when we talk, that people talk very less about anterior surgery, and that is where we wanted to keep this topic so that people should understand how we can save levels, and the experience of Dr. Sajan Hegde will be giving us light. It will be too much if I talk about Dr. Abhay Nene and his academic, as we really know Dr. Nene as one of the fantastic academician, a true leader, and he's one of the stalwarts from Mumbai practicing at Leelavati and Bridge Candy Hospital, and he's always there to support all the academic causes for us. We thank you, Dr. Nene, for being there as an academic chair for today's program. At the outset, I would like to thank this national faculty, the expert faculty today. We have Dr. Yogesh Pitwa, the man who is changed the practice in Bangalore. He's one of the pioneering spine surgeons in Bangalore who started spine surgery practice way back, almost 15, 17 years back in Bangalore. And Yogesh is known for his academic as well as research work, does a lot of degenerative and deformity practice. At the same time, Yogesh is a true friend. I would like to thank Yogesh for being there today, for giving us your expert inputs for today's webinar. We have our next speaker faculty, Dr. Rohit Amritanand. We all know Rohit as one of the true academicians, always there for all ASSI and AO spine meetings as a faculty and sharing his knowledge from Vellore. Rohit is doing tremendous work in Vellore, which is in southern part of India, and we look forward for your inputs for today's webinar. We have our next speaker and faculty, Dr. Ankur Nanda. We all know Ankur as one of the most vibrant spine surgeons from Delhi and Indian Spine Injury Center. Dr. Nanda is doing extensive work, and he's got a lot of hands-on work in robotic as well as degenerative deformity, as Indian Spine Injury Center is doing incredible work with their great team today. And we welcome Dr. Ankur Nanda for today's webinar. We have our next faculty, Dr. Vijay Kamath. Dr. Vijay is again one of the important and very senior faculty, renowned faculty from Bangalore, and known for his work in spine deformity as well as degenerative work. Dr. Vijay Kamath also is known for his research work and publications. Also, he's in teaching and academics. We welcome Dr. Vijay for today's workshop. Vijay is a true friend from many years, and I was delighted to get Vijay on panel for today's deformity session. We have the next faculty, Dr. Chirayu Pamecha from Rajasthan, India. And Chirayu is one of the most eminent spine surgeon from India and Rajasthan, doing great work in Udaipur. And they do a lot of congenital and AIS deformities. And he has got a foundation where they help a lot of poor children also, along with his Kubja Foundation. We welcome Chirayu for today's webinar and giving extensive time for us today. And we have the last speaker faculty, Dr. Rahul Chaudhary from Pune. Dr. Rahul is extensively trained in India and US. Rahul does a lot of deformities and degenerative work, and Rahul is known for his academic contribution in Pune Orthopaedic Society and Pune Association of Spine Surgeons. And he's a very active member in Pune region. We all welcome Rahul for today's workshop. Thank you all and Pune Orthopaedic Society for this extensive deformity congress and one of the largest congress in Asia Pacific region today. I hand over it to Dr. Abhay Nene, and we'll start with the proceedings with Dr. Masato Tanaka's first talk. Over to you, Abhay.
So many stars. I advise all of you to use these dark shades to get over the glow of the faculty that's staring down the screen. I think it's a compelling faculty, and the topic is so interesting that we had to kind of put everything in it, and we put everything in it, and we're going to give each faculty ownership of 10 minutes of time to give their little bite on the subject that's given to them, which means that everyone will cover a part of the subject which is dear to them, and whatever you say is going to be pearls of wisdom to us, sir. So without much ado, let's call on the Santa Claus of Japan, our very, very own dear Masato Tanaka, who's who's the flag bearer for the country, and he's a very, very popular figure in the Asia Pacific and in the world. And Masa, my dear friend, is going to talk on reduction of high-grade spondylolisthesis. Any questions, please put them out in the box that you have on whichever modality you're watching, and questions will reach out to us and we'll have them answered. Over to you, sir.
Good evening, dear colleague. It's a great honor for me to attend this wonderful meeting. My name is Masato Tanaka from Okayama University, Japan. Today, I'd like to share knowledge about high-grade spondylolisthesis. There is a controversy about reduction of high-grade spondylolisthesis. Some reports say in situ fusion is enough. Some reports say reduction is necessary. However, we all know we shouldn't compare apples and oranges. This is the content of my talk. Let me begin with classification talk. This is a famous classification for AIS. With this classification, we can communicate without a big misunderstanding. Myodin grade system is one of the most famous classifications. However, because of this, we misunderstand of the real problems of high-grade spondylo. Which classification is based on its etiology. The high-grade spondylo are mainly dysplastic ones and some are ischemic ones. The most important classification is spinal deformity study groups classification. This is based on three concepts: degree of slippage, pelvic incidence, and spinopelvic balance. Let me explain this classification for young doctors. Step one is to check the degree of slippage by myodin grading system and divide it into two categories, low grade and high grade. Step two is check the pelvic morphology by pelvic incidence for low grade spondylo. PI less than 45, small PI or nutcracker type is not likely to progress. PI more than 60 degrees, large PI or shear type is the most likely to progress, and then classified into type 1, 2, and 3. Check 3 is to check the pelvic compensation by PT for high-grade spondylo. If the patient's PT is normal, it is balanced pelvis, then classify into type 4. If not, classify into type 5 or type 6. Final step is to check the global balance by SVA. Type 5 is a balanced spine, and type 6 is unbalanced spine. This is the summary of spine deformity study group classification. Let's move on to natural history and risk factors of progression. This is a NAS guideline for spondylolisthesis. The incidence of ischemic spondylolisthesis are about 5%. Spondylolisthesis occurs in about half of patients with spondylosis. 360 fusion is better than posterolateral fusion. Unfortunately, there is no comment about high-grade spondylo. Pelvic morphology or PI is very important parameter for spondylo. Greater PI may lead to the development and the progression of vertebral slip. That is why type 3 is a high risk of progression compared with type 1 and type 2. Spinopelvic alignment affects spondylolisthesis. Dysplastic changes are important of slip progression. The posture is abnormal in high-grade spondylo, especially with a retroverted pelvis. That is why type 5 or 6 need to correct sagittal malalignment. Other risk factors are female gender, slippage more than 50%, young age, great slippage angle more than 55 degrees, and dysplasia. Let's move on the surgery part. MIS decompression is indicated only for radiculopathy with type 1 or type 2. No low back pain, no spinal instability, and only for senior patient. MIS fusion is very popular technique for type 2 or type 3. If you would like to choose direct decompression, MIS TIF is better. If you are fond of indirect decompression, mini ARIF, or nowadays, ORIF 5-1 is available. This is our new technique of C-arm-free ORIF 5-1. Without C-arm, we can perform this MIS fusion under navigation guidance only. For type 4 or myodin grade 3, you sometimes need horizontal reduction for solid fusion. This has a special mechanism to reduce slip. Another option for type 4 is in situ fusion. Fibular dwell technique from posterior, that is Borman technique, is very safe procedure. That is very old technique, but historically important and very safe. Recently, there are lots of modified Borman techniques. They use a cage or bolt instead of fibula. This technique is also called axially. Another technique is reverse Borman technique. The cage is inserted from anterior approach. Dr. Kulkarni, as you know, reported MI strip for spondylolisthesis. However, as you know, reduction with MIS technique is very difficult. This technique is from Japan, transdiscal pedicule fixation and transpedicule bone graft. However, with this technique, you can reduce the slippage very little. Harms and Schöffelberger reported partial reduction with S1 dome osteotomy. The sagittal correction is very good, mainly because they use SAI screws as strong anchors to pelvis. The most aggressive technique is L5 barterectomy or Gaines technique. The concept of this technique is so excellent. However, there were lots of unacceptable complications. Another paper from India, partial resection of L5 from anterior. This technique is also unique modification of Gaines procedure. The main topic of my talk, strategy for high-grade spondylolisthesis. Most authors recommend for UIV, it should be more cranial to L4. For LIV, it should be pelvis. In my opinion, SAI screws are the best option for pelvic anchors. Reduction still remains controversial. Unfortunately, there is no prospective study. Many retrospective studies are profound heterogeneity, including SD type, patient age, surgical method, and follow-up period. And also, we don't know the standard evaluation system. Advantages of in situ fusion are it's very easy to perform, less neurologic complications, and acceptable long-term result. Disadvantage of in situ fusion are high rate of non-union, slip progression despite solid fusion, sagittal malalignment, which affects QOL of the patient, and dissatisfaction with appearance. Advantages of correction of sagittal malalignment are biological advantages, improve the sagittal malalignment, which also improve the patient's QOL. Last year, there is a publication from multi-center study. More than 60 high-grade spondylo. Balanced postoperative group has a better outcome of SRS-22. Let me clarify two meanings of reduction. One is horizontal or axial plane reduction. As you know, 2/3 of lumbar lordosis was built in L4 and S1. For spondylolisthesis, this reduction means nothing. Spondylolisthesis, it's nothing. In this concept, in situ fusion is much better. The other reduction means rotatory or sagittal reduction. This reduction is mandatory for spondylolisthesis or type 5 or type 6. If you are planning to do this reduction, you need special tools. This is our strategy. Type 4, partial horizontal reduction or in situ fusion, mainly for solid fusion. Type 5, posterior sagittal reduction as much as possible. Type 6, posterior sagittal reduction is mandatory, no gains procedure. Let me present my own case, 12 years old female, L5 spondylolisthesis with L5 paralysis. She had also urinary incontinence and pes cavities. If you look at the corner radiogram, 42 millimeter trunk shift, pelvic obliquity, curve angle was 30 degrees. Lateral radiogram showed thoracic hypokyphosis, lumbar hyperlordosis, but SVA is normal. PT is 25, so this is type 5. MRI shows severe stenosis at S1 level. So this is a summary of the patient. I'd ask you, the member of Indian group, so what is your surgical plan?
Bhauk,
I
can you take a bite at this? Bhauk?
After this, I will show you the result.
Sure.
Yeah.
Especially the Vijay, come up.
Bhauk,
Are you
what
there?
would your strategy be?
Okay. So anyone
Yes.
for this patient.
So I will take a posterior approach in this case, and there is a little bit of rotatory deformity as well, so that the spine is going sideways as well, the coronal deformity as well. So I will use L4, I will use the L5 screws, I will use the sacrum, and I will take a unilateral iliac screw. I will not use S2 LR iliac because I think in children it is better not to touch the sacroiliac joint. So I will just use a temporary iliac screw for 2 years maybe, and then I will try to reduce it as much as, and maybe I will do the sacral dome osteotomy as well in this case.
Right. So you'll try to get reduction and you'll avoid an S2 LR screw and you'll take L4. And you spoke about temporization, which means you intend to take the implants out after fusion.
Yeah, after fusion. So I will use the iliac screw.
Vijay Kamath. Masa is very close to Vijay.
Vijay, can we have a quick response?
Vijay, are you there?
Yeah, I'm there. Hi, Masa.
Oh yeah. What is your opinion?
Yeah, I mean, I would do the same thing. I would do it all posterior, but I would definitely include L4 into this. And I would think the amount of stress that I'd get on these implants would be pretty high. So I'd put a S2 iliac screw as well. I'd put an S2 iliac screw. I wouldn't just try and leave the whole, instrumentation just on S1.
Right.
So I would go for a partial reduction.
If you look at this, spinopelvic balance is so bad. How do you reduce this? So bad.
Yeah. So the first thing is I'll put the screws in S1 and make sure I put my screws in L4 first and distract it out, very gently. That will help to sort of slightly, reduce the kyphosis at L5. And then, very, very carefully, I'd also probably very carefully remove a little bit of the S1 dome, so that when I'm trying to reduce, I'm not actually lengthening it. I'm just sort of very partially, and I'll try and just get a partial reduction. And even if I get a 50%, I'll be able to get a cage in between so that I can do, get an interbody fusion. But I put an S2 iliac screw.
Is neuromonitoring is a must for you, Vijay?
Absolutely. We would not do this without neuromonitoring.
Okay.
Anyone against putting an L4 screw here? Personally, I would do it without an L4. No one in the house? Can you speak up? Masa, what do you think? What is your solution? The controversy is about reduction. The controversy is about going to L4.
I show you the result. So just L4 is not enough. Okay. So I do L3 to pelvis, S1 dome osteotomy, almost the same of Schaffel-Berger technique. I show you the video. First, we put SAI screw and the pedicle screw in L3 and L4. Then decompress L5, S1 lamina. After S1 dome osteotomy, sagittal reduction with this special breaking Jackson table to make good lordosis, not only the rod. And then the final step is cantilever technique, like this. These are the postoperative images. This looks nice. However, 1.5 years later, rod breakage and the slip again, because this is not enough. So we perform revision surgery with fibula graft and 3 rods, 4 SAI screw. These are the final follow-up. This patient satisfied the final result just for now. Thank you for your attention.
Thank you so much, Masa. That was good learning. Rahul, can you unmute yourself and tell us about this issue of going up, because you say going up to fix the relatively horizontal.
Yeah, it is just my thought. Sometimes I just feel that maybe going up to the horizontal, relatively horizontal vertebral body, up maybe three or whatever, two or three.
So going up to a body
I
which is
think
horizontal.
maybe it's better.
Right.
Relatively, not exactly, but at least to some extent, it should be more horizontal rather than into the lordosis.
Does anyone in the house believe in the shorter fusion? Kyle Lam, do you want to say something? Yes.
I've done about a series of 12 of these where you go posteriorly, but anchor L4 pedicle screw. I wouldn't go to 3. The L5 pedicle is going to be really difficult to get in, as you know. I think with modern navigation, it makes life easier. It's almost like angled that way. I think the importance is that when you do your dome osteotomy, you have to release it enough so that when you reduce it and take away the transverse processes, often is the L5-TP that actually pushes on the nerve root. So you have to free that up. You have to involve L4-4 here because typically the L4-5 facet is damaged. So by the time you try and get your reduction screw from L5 to go back up, the facet is damaged already. The question is whether you want to go into the iliac. I mean, I will try and aim put an S2 screw in rather than go into the iliac and do a bicortical fix. Often if you do the dome osteotomy, you can get probably 70–80% reduction, certainly in my hands. And I would go anteriorly. I do a lot of anterior surgery. And if you do reduce it back to maybe a grade 2 or grade 1, you can go anteriorly. If you don't reduce it more than that, then you can't go anteriorly because it's almost impossible to go over the pelvic brim.
Right.
So, I know BMP is something that we frown upon in pediatrics, and I have done quite a series of these, and I'll use ALIF cages with BMP at the front with locked screws as well. So that's my approach. Posterior.
Thank you so much. That was enlightening. Masa, one final comment from you. You chose not to reduce the L5 here, though it was an imbalanced pelvis. So can you take us through that thought process?
Because the first attempt is I completely reduced, but it was failed. That's why for the second chance, there is no third chance. That's why I choose this partial reduction with Bowman technique.
Right.
So, and 3 rods, 4 SI screw, but I'm not sure this is enough or not. Thank you.
Can I ask Masa
Yes.
why he didn't use a cage the first time?
Yes,
And
because
L5 is
bone
not-
on bone. I thought bone on bone fusion.
So as you can see, a lot of questions can get thrown up on a relatively straightforward topic like this. And
Out of
Masa,
time. Thank you.
thank you for presenting this so elegantly and so much in time. We're going to take a U-turn now, and we're going to move to another huge star faculty, this time from Pune, Dr. K.V. Menon. And he is, one of the big guys who's, been teaching how to plan scoliosis surgery. And today, in 10 minutes, he's going to need to tell us how he plans his method of planning surgery in adolescent idiopathic scoliosis without really using any classification. We call it the KV classification. Over to you, sir.
Good evening, gentlemen. Can you hear me?
Absolutely.
Yeah, so I'll talk about how to do a scoliosis surgery, how to plan a scoliosis surgery without sticking to a classification. Let me start with this case. She's a 12-year-old girl, Visa 2, and she's got this deformity, which you can see. Functions are all normal. There's nothing major happening. There's no major neurological issue. Her right shoulder is up, as you would expect, and she's got a little bit of truncal imbalance, which you can see there. That's her standing AP and lateral X-ray. The PT curve is about 20 degrees, the MT curve is 55, and the lumbar curve is 40 degrees. That's the lateral view, which you can see, the sagittal plane. So it's all written there. The main thoracic curve is 55 degrees with the apex at D89, which is quite normal. It's correctable up to 22 degrees, not a bad curve. The lumbar curve is 40 degree, but very flexible. It's correcting on side bending to 8 degrees. And it's what you might call a Lenke C type of curve pattern. Here are the two side bends, and look at the side bends. It will show you that the lumbar curve is correcting fully, the picture on the right side, and the left side shows the thoracic curve is also not too bad. It's quite flexible. Okay. Now, how do you plan this case? Typically, you would look at what Lenke classification it is and how do you proceed in a Lenke type 1, selective thoracic fusion, etc., etc. But this is what I would do. I have a reservation of using classification, though Lenke is the most frequently used classification. A lot of people use King and Mo in Europe and in India. PUMC is very frequently used in other parts of the world, in Asia, East Asia, etc. But how do you choose this classification? Is it because Lenke is American, we like American, or his is the most published? Some of them are so exhaustive, they're difficult to memorize. And future parameters that you might want to add in, for example, axial plane location, are currently not included. If you do include it, I'll show you what happened. So to summarize, what would happen is this curve, which is a type 1 King and Mo, and it's a type 2 King. Now, it's just a question of semantics, nomenclature.
I guess you're not going to be participating a lot.
You will find that depending on what classification,
either in surgery or in the course, or you're going to get to.
So that's one of the issues with this. Now, let's take Lenke, for example. He's got the 6 curve patterns. And the moment you add the sagittal plane to it, it becomes 46 subtypes. What would happen if you added 3 axial planes, mild, moderate, severe axial plane deformity? It will become 132. Can you imagine planning a case with 132 subtypes in a classification system? Obviously, that's not possible. And then the moment you go deeper into it, you're going to hear about it later today, you have outliers and rule breakers, and then you have to bring in newer terms like last touch vertebra. If you're still not satisfied, you have to polish it further and make it last substantially touch vertebra, etc., etc. So you're changing the rules, you're adding on every day. And let's look at the actual evidence about the variability. European Spine Journal published these 2 papers in 2007. They are remarkable. 32 scoliosis surgeons, SRS members, were asked to plan 5 cases. And you know how many levels were different? Not 1 level or 2 levels. There were 6 levels variability. And how many screws were more or less? 30 screws, up to 30 screws were variable, different between the surgeons. And guess what classification they used? They all used one classification. So much so for the utilization of that classification, the utility of that classification in planning surgery. So what we've been teaching for the last 15, 20 years is this system. You basically look at the curve, whichever is your main curve. If it is thoracolumbar or lumbar, then you might want to do it anterior. All others, you want to do it posterior. If it is posterior, you would look at the strategic vertebra. And the bottom rule is the same for all. The UIV is usually the UEV plus 1. The SV, we would change it to an adjusted SV, which I'll tell you about, which will be the LIV. And then you revisit the upper end and the lower end. The lower end is revisited, the LIV is revisited based on the side bending films. The upper end vertebra, UIV, is revisited based on the shoulder balance and the structurality of the thoracic curves. And if you have any doubts at any stage, remember the golden rule, UIV is UVV plus 1, LIV is adjusted SV. Okay, so let me tell you the logic behind this. You want the LIV to be horizontal. It has to be parallel to the pelvis. And therefore, the column, the fusion column that you will create is perpendicular to the pelvis, and it is centralized over the spine. Imagine what would happen if the LIV that you select is lateral to the sacral line. Your erected column is going to be there, and that's clearly not a happy situation. Or imagine if the LIV that you select is not horizontalizable to the pelvis. You will have an oblique LIV, and then the column that you erect, the fusion column that you erect, is going to be like that. Okay, so clearly not a desirable situation. What would happen if the LIV is rotated too much? If the LIV is rotated like this, you would have an abnormal rib hump on one side, which is again clearly not a desirable situation. So basically, there are 4 rules for LIV adjustment. One is, on one of the side bends, the CSVL has to bisect it so that we are assured that the LIV comes back into the center. The end plates have to be parallel to the pelvis, the lower end plate, on one of the side bending films. The disc below it has to be mobile on either side bending films, and it has to be neutrally rotated. Now, how much flexibility in these 4 criteria you are willing to compromise, how much are you willing to give away, would depend on how many motion segments you can save. Let's come back to the patient who we saw. So let's look at the picture on the left side. It shows you that L3 and L2 are both being bisected by the CSVL on that side. None is being bisected on this. Okay. And let's look at the horizontalization. The L3 is clearly more horizontalizable with the pelvis on the left side bending film. So that is a better choice than L2 in this particular case. What about the disc mobility? If you compare the discs on either side, you can see the discs are clearly mobile. Whether you choose L2 or L3, both are equally acceptable. Now look at the rotation. L3 is significantly derotated. It's neutrally rotated, almost normal. I won't say 100%, but nearly normal. So L3 in this case is a good selection. So what are we really assessing? Is the final LIV that you've selected centralizable over the pelvis? Is the foundation horizontal to the pelvis, horizontalizable? Are the discs below that mobile enough to allow compensation, automatic neutralization if anything abnormal happens? And is the LIV neutrally rotated so that the rib hump is taken care of? If you don't do this, look at what would happen. What is the abnormality here? The curve is corrected well, but the LIV is clearly not centered over the CSVL. That's what has happened. Look at this example. The last screw on the right side is missing. And because of that, the foundation is no longer horizontal with the pelvis. The LIV, the effective LIV is no longer horizontal with the pelvis. That's why you have this oblique situation. So similarly, you have a UIV problem as well. If the UIV selection is not appropriate, you can get shoulder imbalance, you can get progression of the proximal curve, etc., etc. So these are the 4 criteria you should select, you should adopt to select the LIV. Let me show you in practice how it is done. So our planning sequence is like this. First, you make sure that the LIV which you select is horizontalizable to the pelvis in one of the side bending films. Next, you make sure that the column or the fusion mass that you're going to erect is going to be perpendicular to the LIV, and the top is going to be parallel to the LIV or perpendicular to the fusion mass. Then you would get a horizontal shoulder. What happens to the spine in between is less concerning. Let the spine remain a little bit curved. If it is a residual curve, it doesn't matter. Now we call a type 1 error is if the LIV that you select is not parallel to the pelvis, then your fusion mass is going to be like this. And that's a type 1 error. Does this happen? Professor Chu Yong sent me this picture of one of his cases which was done in Nanjing Hospital in China. If you look carefully at the second picture, you can see the problem there is that the LIV that he has selected is not horizontalizable with the pelvis. And to adjust that, he had to subsequently go in and fuse towards the pelvis. And that's why he's got this Eiffel Tower construct. The type 2 error is, of course, your LIV selection is horizontal, but the column that you have erected itself is not perpendicular to the pelvis. And that does happen. It does happen quite often. Here's this example of one of our cases. So here, the LIV is almost parallel. I won't say 100% parallel, but it's almost parallel. In spite of that, we've got this abnormality. So we went back in from there, and you compress on the left side, you distract on the left side, compress on the right side, and you automatically brought it back significantly. Though not completely, it has come back significantly. So this is an intraoperative correction technique that we use routinely. So this is a centralizing rod. It's part of the Synthes bolt cutter, rod cutter system. We align it with the bottom 2 screws and see where the center is going. The center is going far right of the spine. And if that happens, once you distract the bottom 2 screws on the left side, the rod is coming back into the center. You compress a little further on the bottom 2 screws on the right side. And once you've done that, now you can see the spine is aligned completely to the center. Now, this is critical only below L3. If your LIV is below L3, if your LIV is above L3, you have enough motion segments, it will automatically balance itself. Now, there's another error that can happen. So far, you're correct. Your LIV selection is correct. Your column selection is correct. But the top is not correct. If your top is not correct, then you can very often have this type of a construct. Now, this is a picture that I've taken off the internet. You can see somebody has done a tether, and post-operatively, his shoulder has become unbalanced, and the T1 has also become tilted. So the strategy that we are telling you is about strategic vertebral planning, and we do not use any classification for this. You don't even have to know what Lenke type the curve is. Once you've decided the curve is over 45 degrees or 50 degrees and you need surgery, you start immediately with this planning protocol. And the coronal plane is the primary concern. We do not look at the sagittal plane or the axial plane in terms of planning the surgery, but for the correction maneuvers, yes, we do look at them. But for planning the surgery or planning the instrumentation, we do not look at them. So we developed this in 2001. It's not my own concept. This is based on the CD principles that I learned in the late 80s and early 90s. And so far, my juniors have reviewed 582 cases with up to 12 years follow-up in this. And we have had excellent results thus far. There are a few bad ones, which I'll show you at some point in time, not in this lecture. So the summary of the strategy that I'm proposing is, the moment you get the curve which you have decided to operate on, decide where is the main curve that you want to correct. If it is thoracolumbar or lumbar, you can consider anterior. Everything else is posterior. If you're doing a posterior procedure, forget about the classification. Just locate the strategic vertebra. Where is the apical vertebra, end vertebra, neutral vertebra, etc., etc. The UIV is always the UEV plus 1. The LIV is the adjusted SV. So first, identify the SV on the standing X-ray, adjust it, push it upwards. You want to save lumbar motion segments, revisit the LIV based on your side bending X-rays. You can continue to push it upwards. Revisit the UIV, which you have selected based on your shoulder levels. And if you have any doubt, stick to the original rule. UEV plus 1 is UIV, adjusted SV, stable vertebra, is the LIV. Now let me come back to this case that we showed you earlier. So this is the planning that we did for this case. This is the preoperative planning. That is the postoperative X-ray that we have obtained, both sagittal and coronal plane, from that same case. Thank you.
KV, that was very succinct and quite simple actually. And I'm going to invite comments from Dr. Yogesh Pitwa and Dr. Rohit Amritanand. But while they are prepping, KV, I would like to ask you, is this oversimplification of selecting levels? What I mean is that, have you had any errors when you adopted this plan?
So we have, as I said, recently looked at 582 cases. We have had some problems, but those problems are not related to the strategy itself, not related to the simplicity of the strategy itself. Those are related to compromises. I said LIV selection, you have to look at the 4 basic principles. Very often, you do not get all the 4 correct. So the minimum that you require is 3. And if you're 2 or less, then you have a problem of selecting the LIV appropriately. Then you can have a problem. And that's where we've actually gone wrong. Now, the advantage of this, you mentioned about the simplicity. The greatest advantage of this is applicable for everything. It is applicable for congenital scoliosis, certainly not neuromuscular, because neuromuscular, very often you need to go to the pelvis. But for all other types of scoliosis, because the fundamental principle is the same. What are you trying to do? You are trying to make sure that the LIV, whichever is the LIV that you select, is parallel to the pelvis and it is central to the pelvis. Those two bottom rules you have to follow. And how much correction you get, whether you want to do Ponti's osteotomy, etc., is it a stiff curve, etc., is your choice. That depends on the curve. But the 2 or 3 basic principles of how to select the LIV, I don't think should change.
Right, lovely. And Chirayu wants to know, how do you plan a selective thoracic fusion by this method?
I don't do a selective thoracic fusion at all. I never do a selective thoracic fusion. To plan for example, this particular case that we showed might seem appropriate for a selective thoracic fusion because the lumbar curve is correcting very well. The rotation is correcting very well. Some of you might have chosen to stop at T12 or even L1, but that's fine. I don't do that. I stick to the bottom rules, and because I stick to the bottom rules, I've never had an opportunity to regret when at least 3 out of the 4 criteria of LIV selection fall into place. The chances, if all 4 fall into place, then none, not a single one, have had a problem.
Fantastic. Rohit, I want your comments on how you select the upper instrumented vertebra. Do you blindly follow Lenke's rules, or is there trick in your up your sleeve?
So for the UIV or the upper instrumented level, I'd go by the shoulder rule. So if your left shoulder is lower, then you go to T4. If it's level, T3, and then if the left shoulder is higher, then T2, and then after that compress it down. That's by and large my strategy for selecting the upper instrumented level.
Right, lovely. Dr. Kyle M, you want to speak up? You want to say what? Because this, yeah, go ahead.
Yeah, thank you, Professor Menon. Very enlightening. I would agree that these classifications are a guide, so it doesn't actually technically tell you what to do. And as you know, Lenke classification really was designed to save lumbar level. So I think given your case, a lot of surgeons would have chosen a selective thoracic rather than going to lumbar. And then my other comment also, Lenke's classification has a cutoff at 25 degrees for the compensatory curve. but it doesn't actually tell you whether you should be doing a side bend or a bolster bend. Because if the side bend touches 26, then Lenke says, but when you do a bolster bend and goes to 24, then you don't fuse the lumbar. So that's another one of my comments. Yeah, so
too many loopholes, right? Too many loopholes there.
So what you said is absolutely evident. So the flexibility of the curve depends on the testing method. For example, if you're doing a supine side bending film, you can get one flexibility. And if you do a fulcrum bend, you can get a different flexibility. Exactly. Isn't that what you just said?
Yes. Right.
Yeah. So the flexibility of the curve is completely different. So therefore, we do not depend entirely on the flexibility. We try to make sure that whatever is the LIV that you select, it has to be horizontalizable in whatever method you do. But it has to be horizontalizable to the pelvis, and it has to be centralizable to the pelvis effectively. And if you don't do that, then there's a chance that you might decompensate.
I mean, that I entirely agree with you. You have to drop it within
that's the basic concept
zone. Yeah, that's why I would have chosen a selective thoracic in your case. I thought it was
that's fine. Yeah, that's fine.
Fantastic. Just to conclude, Yogesh, can we ask you a question because we'll need to move on? Yogesh, what classification do you recommend we all general spine surgeons use? Do you think what do you use and what do you recommend we use, Dr. Pitwa? Yogesh, can you unmute yourself? You're muted.
Yeah. I can't recommend to others. I can only speak for myself because there are too many stalwarts around. So what I follow is I follow the Lenke system, and that's the only thing that I follow. And I just wanted to ask KV sir as to, you've presented something really very different from what most of us are, practicing. Just wanted to know, I mean, it would add a lot of value if you could also analyze as to how many levels chosen were different from the regular Lenke classification system if you were to use that versus your system. Then, many of us can understand how much is the deviation between your planning versus the regular planning that we are doing.
So to be honest, I haven't compared our series with using a Lenke and without using a Lenke. So I don't really know. Having said that, it is my general impression that in most cases, it would match. It would perhaps come to very similar, perhaps one level different, with the exception of the selective thoracic fusion that I mentioned. Those cases where you would choose to do a selective thoracic fusion, perhaps there would be a difference of 2 levels. In all the other cases, it would perhaps match, or it would come very close to each other. And maybe the LIV would be 1 level different, perhaps, at best.
Lovely, lovely. Thank you so much.
I did not use the same protocol as Amritanand mentioned. I used a completely different.
So much to discuss. There are some great points coming. Chirayu says that the lumbar prominence clinically is important. And of course, Dr. Siddharth Iyer says that if you're doing an STF, you can undercorrect. So there's so much to discuss. Let's take these home as, food for thought. And KB, if you can delink and unshare your screen, because I'm about to invite royalty from the field of spine from UK. Dr. Kyle Lam is nothing less than that because he's such a popular surgeon, such a popular academician. KB, can you unshare your screen? Stop sharing your screen, please, KB. Dr. Kyle Lam is very well known in these parts. He's trained a lot of our colleagues and he's a master of the game. Like I said, royalty from UK. He's going to talk to us about a very, very new concept, which is MIS, spinal deformity correction. And I can go on and on about you, Kai. Maybe you should take over.
Thank you, Abhi. That's very kind words. Thank you, Shailash, for inviting me. We have a lot of royalty here in my presence, so I'm blushing amongst royalty. So I've been asked to talk about minimal invasive adult deformity correction. So here's London Bridge, and I belong to a lot of these societies. We're also a robotic center like Sajan Hedger. So I would entitle this My Take on MIS Adult Deformity because everyone has varying opinions. So these are my disclosures. I think the clear issues with MIS deformity surgery really, is the surgeon comfortable and is he able to perform it? And when he starts it, when does he start to push the envelope? we know there's altered deformity in these patients, and sometimes, you know, with previous surgery, the anatomy is very, very difficult to see. These operations are arduous. It creates a lot of mental and physical fatigue. So are there ways that we can improve on the way we correct these cases? And of course, if you don't have technology with us, then fluoroscopy means that you'll be exposed to a lot of radiation. And one of the big questions is, like, are we able to restore the sagittal coronal plane deformity, and how do we achieve the fusion? So let me talk about the targets. So the bottom right photograph, we have Roger Hartl, Emiliano Viale, and Cristiano de Menezes. So we teach on these various topics, AO principles of, number one, who do we target? What kind of technology do we have at our disposal? What kind of techniques can we utilize to correct the deformity? And then, of course, we need to teach and train our colleagues, and then constant updating on technology. And I think, you know, we need to have the appetite. So we put down number 5, the talent. And of course, when we do all this stuff, we need to collect the data, research, and publish it. So I'm going to talk about 1, 2, and 3 mainly in this lecture. And of course, these kind of operations, if you have, it's very costly. So I put a Ferrari up here because they are expensive operations. So in terms of the techniques, I will start talk about techniques first. Here's a pictorial representation of the various surgical techniques. Your P-lift, T-lift, lateral surgery, O-lift, and A-lift. So these are the various approaches that we can use to address the spine. And I think as a surgeon that treats this kind of deformity procedures, you really need to master all the techniques, because you will be using a combination of these techniques, but there will be limitations of the procedure. I use the L-lift, the lateral and the oblique, as well as the anterior lateral A-lift. And you can see here in this slide, at L5S1, you can now address the patient in a lateral fashion and go anteriorly to 5-1. And all the other segments higher up, you can perform lateral surgery or variations of it. So I think part of the issue here in patients who have adult deformity, they have sciatica. So when you're doing a lateral surgery, you really need to trust your lateral surgery. So here's a pictorial representation of how, when you put the cages in, there's great indirect decompression, and lots of papers to show that this is possible, including our publication in 2017. In terms of technology, they're expensive. So this form of navigation, be it intraoperative O-arm or the brain lab intraoperative CT, it costs around $1 million to buy them. And if you have a robot, and lucky enough to get a robot, it costs around $1.5 million. So that's the technology. And with that, you have all this variable instrumentation that allows you to navigate your screws, and also navigate down the tube to do your decompressions and fusions. These are more technology. You have favored angle screws. You have MIS ways of bending the rod. So these are sort of rod bending technologies, if you wish. In terms of technology as well, I like to talk about cages, because now we have lateral cages that allow you to dial in 30° of lordosis, A-lift cages, hyperlordotic cages, again, allowing you to dial up to 30° of anterior column realignment or reconstruction. Let me move just quickly. This is the technology now, it's available. So here we have expandable lateral technology, okay? Now they are very expensive, almost twice the price of A-lift cages. So you can see the video here showing you can dial a lateral cage, okay, up to 30°. So this allows you to perform what I call lateral anterior column reconstruction, okay? Now, Professor Tanaka talked about lordosis. Some studies really show that 67% or 2/3 of the lordosis occurs between L4 to S1. So therefore, when you use this kind of technology, particularly hyperlordotic cages at L5S1, you're able to, what I call, Pimenta calls it, you get lordosis for free if you put a nice cage at the bottom to reconstruct a sagittal plane deformity. Then what about the patient? Who is the optimal patient? So I call it the target. Who do you target? Lots of studies now show that when you lose lordosis, you get compensation mechanisms, your muscles and joints are trying to pull you up, and you get abnormal degenerative changes higher up and imbalance. So this is the, if you like, the cycle of pain that these patients get. And on the right side, you can see a pictorial representation taken from Lenke. If you have sagittal imbalance, you have ankle extension, you get pain there, you flex your knees, so you get knee issues. Then the biggest compensation is pelvic retroversion. You're constantly trying to bring your pelvis upright. Then you get thoracolumbar issues, you get loss of the thoracic kyphosis, so thoracic hypokyphosis, and then cervical hyperlordosis. So all these areas can generate pain. And that's what happens when you get global malalignment. So in your operative goals, the clinical improvement really is to improve your pain, improve your function, get a nice horizontal gaze and your head over the sacrum. So part of that is really to get to re-rotate your pelvis into pelvis neutral rotation. So you want to be able to do that to stand upright. So a lot of this is to do with what I call the numbers game. So the general teaching is to get your SVA less than 5, your pelvic tilt less than 20, and then your PILL mismatch to be matched. So that's the principles. So we are born, if you like, we're ingrained according to SRS Schwab to do this, yeah? SVA less than 5, T1 tilt less than 0, PT less than 20, and this so-called proportional correction, PI to match your lumbar lordosis, even if you're doing a small procedure. But there will be some inherent problems with this so-called numbers that we are taught to use. Okay, so Lamartina and Pedro Bajano talks about how we could use lateral approaches, and he splits them into type 1, type 2, type 3, and type 4 in terms of how we can, it guides us towards when do we do minimal invasive lateral surgery. And if you look at Juan Uribe, this is the ISSG group. They give you a flow chart of when you can do a lateral, an ACR, T-lift, A-lift, depending on how much height you want to restore and how much lordosis you want to get. The same group in 2015 published this MISDEF classification, okay? And they split them according to SVA, pelvic PT, mismatch, and the stiffness of the thoracic kyphosis to decide, do you go minimal invasive, class 1, minimal invasive decompression with interbodies like laterals, or do you consider osteotomies? So they moved on in 2017, okay, with a newer classification, and essentially they've added on a class 5, okay? Class 5 means you have a very rigid kyphosis over previous surgery, and you want multi-level fixation. So they actually did an intra-observer correlation and found this to be very high, at least 0.8. All right, so this is the MISDEF2 classification. Now, I started using the SRS Schwab classification originally, and the type 1, if you like, is the mild imbalance, and we look at the coronal cob to be less than 30 degrees with a global balance less than 5. If there's moderate compensation, the coronal cob goes up, SVA between 5 and 4 and 10, and the pelvic tilt between 25 and 30. And I'll talk about why there may be issues here. And then if there's severely imbalanced, then the SVA is greater than 10 and the PT is more than 30. So the right side, it gives you the pictorial representation of what this means in terms of balanced, compensation, and unbalanced. So in terms of your guidance, this is what we call the mile curve in green. So you can consider an all MIS approach. I don't think we should recommend putting standalone cages, and you could consider percutaneous option after the interbody cages. When you're moderately malaligned, then you need to do a little bit more, consider a hybrid type open procedure with SPOs after your interbody cages. And if you're severely imbalanced, then you need to think about an open procedure with combination of SPOs and even a PSO if you think that you want more alignment. And here you can dial in what I call the anterior column reconstruction using lateral cages and anterior lateral ALIF cages. So here's a type 1 curve, previous type 1 deformity in an 84-year-old with cardiac in the discs. There's some preserved lordosis. That's why he's reasonably well balanced. So in this case, a so-called mildly imbalanced, I offered him a minimal invasive option where I put in interbody cages minimal invasively, and then posteriorly I put in percutaneous screws under navigation. So here there's a frame-based retractor to do the anterior lateral ALIF, and these are the incisions. So this is the balanced type 1. This is moderately imbalanced, but quite a big coronal curve. And these are the parameters on the left side, quite a big coronal club. The PT was 9 degrees and the PI, quite a low PI here. And again, you see how L4 to S1, there's enough lordosis and most of the deformities in the upper thoracolumbar, upper lumbar region. This is the CT MRI scans showing a lot of degeneration of discs with vacuum phenomenon, and also foraminal narrowing over previous laminectomy, 2 lots of laminectomies. So in this case, the patient underwent an ALIF first, anterolateral ALIF, and was able to put in a large interbody cage and then turn it over to do a right-sided, because of the scoliosis was the concavities on the right. Then I did a minimal invasive multi-level lateral cages. And then this is what I call a hybrid approach, where because of high BMI, I split the fascia, I didn't open the muscle, and here I'm using tubes, okay, minimally invasively and under navigation. I'll use a Midas burr, burr the facets, and then I'll put in BMP into the joints. And here I'm navigating the ILEC bolt, okay. And again, I'm putting BMP into the SI joint, into the S2 AI screw for the fusion. And we have this technology where you're able to use this rod bender. You can measure the screw heads, and then you can bend the rod according to the lordosis. So we have what I call an in situ fixation with the rod. Okay, so here we are, and I've closed the fascia. So in this patient, pre and post surgery, I've improved the coronal cob. I've pushed the boundary somewhat because the coronal cob was quite big, and the PT remained the same, and the SVA improved. Okay, so here, this is what I call a type 2 to type 3 moderate curve. I push the boundary, and I'm using Surgery Map here to plan my cages. Now, this is a type 3, 59-year-old chap, severe back pain, long-standing history of scoliosis, treated with a spinal cord stimulator. He had so many injections, ended up with adrenal insufficiency. Okay, presented with this awful flat back deformity. This is the CT scan showing a really rigid kyphosis, really a rigid flat back. This is, if you measure using Lueck's formula, the PT, okay. So if you measure the PT, the corrected PT should be 11 and the lumbar lordosis is 53. So this is his corrected curve. So he's actually severely imbalanced. So using Lueck's formula, I was able to calculate what the predictive value is, right? And then let me show you what I did to him. So this is a stage 1. So I went to the back, I opened up his back, and I did Smith-Peterson osteotomies, and I have this robotic technology now with me. So I was able to use a robot to put in these screws in. So this technology allowed me to put 14 screws in the space of 35 minutes. So a lot less stress with this technology. So that's a stage 1, and I put in temporary screws. As you can see, and I've taken all the facets out, the SPOs. Then stage 2 days later, these are the levels I'm operating, 5-1 up to T12L1 with a minimal invasive anterior single position lateral 5-1 hyperlordotic cage. Okay. And then after that, I would do all the lateral dial-in lordotic cages all up and down his lumbar spine. All right. And that's after the stage 2 lateral 2 days later, yeah? So you see, I've got some pretty good correction there, and I use SurgeryMap to remeasure my parameters. And then stage 3 later, I used a robot again and did a subfascial transmuscular fixation higher up to T11. That's the rod bending technology that we have. So that's the final X-ray. Now, let me move on. So this is pre-surgery. You see all the parameters were red, high pelvic tilt of 40 degrees. So everything was red. And then after surgery, everything is green. So the PTs come back down to 10 degrees. And essentially the upper lordosis, the L4 to S1 corrected. I may have given him a little bit more lordosis, but he's beautifully corrected in the coronal and sagittal plane. So if you like, using lateral surgery, it's so powerful because you can correct the anterior column. And if you stage it, then you remeasure your parameters, because this was the original parameter who was red. But if you remeasure it, there's a paradigm shift because you reduce the surgical footprint. You're able to then do less surgery on him. You don't have to go long. You don't have to do a PSO. So that patient stayed in hospital for about 7-8 days, 500 ml blood loss, and had a very good, excellent result now 1 year down the line. Now, I'd like to talk about the parameters that we discussed earlier on, because you really have to be aware of the patient with a low PI. So if you look at this pre-op patient here, the PT is measured at 15 degrees, so considered mildly imbalanced. There's loss of lumbar lordosis, okay? But if you measure him correctly, because the PI-LL mismatch is actually 0, so Schwab's classification says you're within the normal range. But if you use the Loex formula, this patient technically is sagitally imbalanced, all right? So the SVA is actually 130 degrees. So beware the low PI, because if there's a low PI secondary to adjacent segment L4-5 disc failure, then consider minimal invasive hyperlordotic cage at 4-5 and look at the parameters, beautifully corrected in this patient with a low PI. So the current issues, and I would draw your attention to these papers on the right side, have a good read of those papers. Because when you have a low PI, the lumbar lordosis tends to be greater than the PI. If you have a PI of about 50 degrees, they are equivalent. With a higher PI, you need less lordosis. So this formula of the PI-LL mismatch of 10 degrees is only valid for small PI, okay? So there's lots of numerous estimation errors, because a low PI means you don't get it, you're not dialing in enough lordosis, and a high PI, you're performing too much lordosis and you get a PJK. So consider these formulas when you're doing your adult deformity surgery. And also think about your Roos-Lee type curve when you're doing a correction as well. What do the studies show? ISHG shows that MIS surgery, less significant complications, consider less invasive techniques. This paper shows morbidity of adult scoliosis surgery minimized with less invasive surgery. This is a meta-analysis basically saying that both the minimal invasive and open approaches are comparable, but MIS associated with better safety outcomes, while open surgery gives you greater correction of spinal deformity. So these are all the benefits for the minimal invasive lateral surgery. Better lordosis, better footprint for indirect decompression, shorter surgical time. And beware, because some studies now show that if you do use the ACR technique, PJK is still around 30 degrees. And it's also a good salvage for rod failure for the adjacent discs. And it prevents you from doing a PSO, which carries a lot of comorbidity. Usual caveat, age, comorbidities, the density of the curve. Think about the stiffness between whether you want to do an open versus MIS procedure. You got to be well trained, work with your colleagues to develop this service, publish your data. And in terms of your surgery about parameters, beware of the low and high PI when you're doing your corrective surgery. So all these principles fit the AO principles of stability, biology, alignment, and function. And I want to say, a Confucian philosophy for MIS deformity surgeons, it's not for everybody. MIS deformity surgery is not for every surgeon, it's not for every patient. A good MIS deformity fusion is better than a good open fusion. A good open deformity fusion is better than a bad MIS fusion, and a bad MIS deformity is worse than a bad open fusion. And it does not matter how slowly you go as long as you do not stop. Everything, MIS deformity surgery, has its beauty, but not everyone sees it. Thank you very much.
Very, very intriguing and great philosophy at the end, Kyle Lam. You really stood up to the reputation that you come with. Just one quick question, because we are pushing time. Do you think that this technology will eventually go forwards towards the treatment of AIS also?
Yes, I think so. I mean, there's some MIS, tethering approaches. I'm still not sure whether that's a way forwards. I know some surgeons are doing mini open Wiltsy approaches and then fixing, the upper curve and then the apex and the lower curve. So that still needs to be evaluated. One of the worries in AIS in pediatric is that how do you get the fusion? I guess they fuse nicely anyway. So when you touch the periosteum, they fuse. So
awesome. Masa, your quick comment?
Okay. So I'm also a big fan of circumferential MIS for adult spinal deformity. But in your technique, why you choose 3 stages? Usually 2 stages is very popular. Why? What's the merit of 3-stage surgery?
Yeah, thanks, Masato. I think in that case, I probably may go back to the 2-stage, maybe the anterior. My concern with him was he was so stiff and rigid, and I just wasn't sure whether I could get my cages in, the lordotic cages in, and not, if I can't get the cages in, I still have to open the back up. So if I did the SPO, I was able to put nice cages in. But that didn't take me long. The first stage maybe took me with a robot, I don't know, an hour and a half, 200 mil blood loss. And it was two days between the 2 stages.
Yeah, we'll ask our own man, Vishal Peshettiwar, his take on this. Vishal.
Well, this is very, it's too advanced for me. I've just entered lateral minimal access surgery now. But yes, it's, I believe everything what we thought was not possible is now becoming standard with minimal access surgery. And what he's showing is beautiful results, and a very going staged, I think, is the way for this surgeries, and not doing everything at one go and getting a bad result. So,
right, got it. And Ankur, I would like to ask you, because in your city there have been reports of MIS surgery for AIS. Dr. Jaiswal doing those small holes and then putting screws and doing small fusions and a transmuscular rod. What has been the feedback, and what is your opinion?
I think so. Our experience in the same has been limited. Dr. Jaiswal has been doing it a lot, but he has been mainly doing it for more of a juvenile age group and an early age group rather than AIS. But yes, I think it has got a huge role, and I think as our understanding improves about it, probably that is the way which is going to be there in the future.
Awesome. Great. So lovely discussion. Thank you.
Right, can I make a point?
Yes, Dr. Kyle Lam first and then Dr. Sajan. Dr. Kyle Lam, you wanted to say something?
Some of my colleagues are even pushing the boundaries with deformity surgery. They're doing single position lateral and robotic screws out up and down the back. I'm just not quite sure whether that we should be pushing that boundary for the time, because it's a sagittal plane deformity and also coronal. So how do you get the correction when you're lateral putting screws in?
Right. Yes, Sajan.
So we have been building our experience with the OLIF technique for adult deformity, and also using the robot. For short fixations, we are doing single position all in one, that is anterior at the same time and posterior using the robot. For other cases, we need to do a more extensive posterior instrumentation. We perform the anterior first, get the patient up and about, and look at their leg pain, back pain, etc. And if they are better, then we just go ahead with the robotic minimal invasive posterior fixation. Minimal invasive, maybe a hybrid sometimes.
Fantastic. Thank you so much. So
one last comment, if that's okay.
Please, yes.
Sometimes these adult deformity are what I call flexible rather than fixed. So when you get an X-ray, they are what I call globally imbalanced because of the nerve pain. So and Sajan is right. If you do the interbody, get the indirect decompression, it's amazing how much they correct. So it tells you that this is more flexible than you think. So that stage approach, I'm a proponent of.
Yes, I agree with Kai.
Superb. Thank you so much. We have a dude from Delaware waiting, so let's not keep him waiting for too long. It's early morning in North America. And if there's one person, one American who makes the headlines bigger than Donald Trump in our part of the country, it's Suken Shah. He's indeed poised to be the king of deformity. He's already sitting on the prince's throne. At a young age, he's achieved so much, and he's a legend of sorts in some of the biggest societies that deal with spinal deformity surgery. And we're extremely lucky, Suken, that you could take time and share some of your expertise with us. And the topic that you've chosen seems to be a real kicker. It's what works and what does not work, the rule breakers in the Lenke classification. So it's all yours, Suken.
Great. Thanks, Abhay. How's the volume? Is the volume okay?
Absolutely.
Good.
Suken, can I just interrupt you before you start? So
Sure.
You have a president from your hometown, Delaware.
Yes. I mean, hopefully that'll be announced today, but he lives about a mile down the road, and they've blocked off his street for a few days now to provide security. So it's been interesting to watch, but hopefully everything will be locked up today.
Lovely talking to you, Suken. Go ahead with your presentation.
All right, great. So there was a spirited discussion about classification and rules and so forth. So I think the main point about this talk is what the rule breakers are. But I think we need some background, first of all. For instance, why is a classification even important? And I feel strongly about this because we have to have some sort of standardization. Now, these shouldn't be considered rules because we should be able to follow our experience and our instincts whenever possible, but we need something to give guidelines, especially to younger surgeons and our trainees, in order to provide some standardization. So sometimes it involves choosing the best procedure, as you just learned from our esteemed colleagues in MIS deformity. But sometimes it involves choosing the right levels. But one thing I want to emphasize is the Lenke classification doesn't tell you exactly what levels to do. It only gives you a guideline as to what regions of the spine to consider fusing. It's an excellent communication tool. For instance, if I told Abhay that I have a Lenke 2C curve, he understands that in his mind exactly. But I think also importantly for the harm study group, it's an important research tool. Everybody's familiar with the Lenke, with the King-Mo classification. This was the first one that was coronally based, 5 curve types. It focused our attention on the opportunity to do a selective thoracic fusion in the King 2 and was the first to describe this double thoracic curve pattern in the King 5. But in addition to being the gold standard for 20 years, it did have its problems. It had very poor inter-observer reliability. It was only involving the coronal plane. There was often a tough distinction, even in an article that Howard King wrote himself later, identifying the King 2 curve. Triple major curves weren't even considered, lumbar curves weren't even considered, and was based on Harrington distraction principles. And as we progressed to more segmental fixation and now pedicle screws, it has really fallen out of favor. This was now replaced, at least in North America, by the Lenke curve classification, published in JBJS in 2001. It had 6 goals. It needed to be comprehensive, that is all curve types, thoracic and lumbar, more than 1-dimensional, but 2-dimensional. The initial effort was for 3-dimensional, but we don't have that capability yet. it had to be treatment-based. What regions of the spine should be fused? It had to be reliable, had specific objective criteria, not kind of a spitball or this is what I think, and had to be very practical. Initially, it seems quite daunting. There are 6 curve types and sagittal and lumbar modifiers, but when you break it down into a triad classification, it's actually quite easy. First, you take the 3 regions of the spine, proximal thoracic, main thoracic, and lumbar, involving the 6 curve types. You then classify as to what's structural, what's non-structural. The largest curve is always the main curve and is always structural, and then the compensatory curves are then determined on structural characteristics based on flexibility, on side bend, or on kyphosis. So the basic premise is you fuse all structural kyphotic curves and you leave the flexible ones alone. And then you have the side bending criteria. So for instance, this curve bends to less than 25 degrees, sorry, greater than 25 degrees at 36, so that's considered structural. When you have a kyphosis, that's considered structural. Next is the lumbar modifier. How deviated is the lumbar curve off the center sacral line? Large lumbar curves deserve respect and consideration for fusion. And then finally, the sagittal modifier was very important when we were doing a lot more anterior fusions. Anterior treatment is coming back. Do not prescribe anterior treatment for kyphotic curves, and we want to restore kyphosis on those hypokyphotic curves. So basically, this breaks down to 14 different curve types, and a recognition of those different shapes is presented here. The algorithm was look at the x-rays, classify the curve, consider what treatment you want to do, and then audit and look at your outcome. These are some of the surgical treatment axioms based on that classification system. A short fusion is better than a long fusion. Straight is better than scoliotic. Try and get balance in both planes. Fuse the largest curves and then decide which of the smaller curves need fusion. And these are also the important assumptions, which is where I think some other classification systems might diverge. Always fuse the largest curve, fuse minor structural curves, leave non-structural curves unfused. And you have to understand this classification has a strong bias towards selective thoracic fusion, basically because the developers of the classification system had that strong bias as well. What did it do? How did it get us forward? Well, it included lumbar curves. It forced us to look at the sagittal plane for the first time and analyze these films more carefully. We hardly ever miss proximal thoracic curves. We hardly ever miss thoracolumbar junctional kyphosis. And we're more thinking about selective thoracic fusion than ever before. Now, this is a 13-year-old female with 2 large curves. They're both rigid on side bending. So we attribute this to a 3CN, and this requires both curves fused. But never does it say the fusion level should be T4 to L4. That's something that the surgeon has to take on himself or herself when looking at the flexibility and what the patient wants. Here's another curve. This is a 1C because the lumbar curve is very flexible. This patient desires continued mobility. A selective thoracic fusion turned out to be a very good outcome, both on the coronal and sagittal planes. There's excellent balance in both. Well, how often does it work? After the classification system came out, 90% of the cases, when looked back in a retrospective view, did follow those Lenke rules. But this article was written by the Lenke developers, so you would think that they were following their own rules. Did the Lenke classification system change treatment going forward? In a prospective study, about 88% of the cases in the harm study group did follow those rules, but there was some divergence. Up to 29% of the time, there were other factors that dictated treatment for specific curves. And this is when you get the different bias of different surgeons. Most of the time, the rule breakers involved fusing longer than what the Lenke classification system described. So why not 100%? Well, our treatment algorithms are pretty complex. Sometimes we fuse when the classification system says no. Sometimes we don't fuse when the classification system says yes. And it's these borderline cases that are problematic, and we end up breaking the rules about 15% of the time. So when thinking about what Professor Lenke describes, sometimes you don't want to go against the Godfather and prescribe these rules. And I've given this talk with Larry in the room, and he will actually agree that many of these issues were problems when he was developing the classification system, but those were limitations at the time that hopefully with 3D we can get better. First of all, the bending X-ray assessment is somewhat arbitrary. Why 25 degrees? It's dependent on patient effort. And as was mentioned before, the fulcrum and the supine bend do differ. In the article, the films were done supine. And so if you want to look at curve rigidity, you really should look at the supine bender, especially for the lumbar curves. There's no rotational assessment because this is a 2D classification system. When we go to 3D, we will have rotational assessment. But this involves an important point of looking at the patient and looking at that lumbar prominence to decide whether that lumbar curve needs to be fused. The classification system doesn't take age into account. Growth is a huge variable for adding on and perhaps crankshaft. And so we really may have to do a longer fusion in a younger patient to avoid adding on or that lumbar curve progressing later. The upper instrumented vertebra, there are paroxysmal thoracic curves, PJK, shoulder balance to think about. None of that is really discussed in the article. Or the lower instrumental vertebra, what level to specifically choose is also not discussed in this specific article. And I'll go over some of these Lenke 1 subtypes and the L3-4 conversation because the lumbar modifier doesn't predict well. This is the same patient with right and left bending films. Both curves bend out to less than 25 degrees. What do you do? Well, you go back to rule number 1. The major curve is the largest cob, and that's always the one to consider fusing. All Lenke 1 curves are not the same. This is a comparison of typical thoracic curves in the Harm study group. The typical curves have an apex between T7-8 and T10. There are some curves that have a proximal apex and some curves that have a distal apex. They're all considered Lenke 1 curves. The problem here is the distal curve apex. You need to consider having a lower instrumented vertebra or else you'll run into add-on. As illustrated in this table, the LIV for those distal apical curves was L2 most commonly, provided an excellent result. Professor Sook's paper for selective thoracic fusion described as end vertebra plus 1 is the best end vertebra. And in this diagram, I think a good rule of thumb, which was subsequently published by Lenke, is that when you draw the center sacral line and you pick the last touched vertebra, that's going to be an excellent lowest instrumented vertebra to consider. If you go proximal to this, you will end up getting add-on about 40% of the time. And further on that theme of variation in Lenke 1 curves, these are both Lenke 1 curves, but you'll notice that the lumbar curve looks quite a bit different. On the left, you have a lumbar curve basically almost crossing midline. On the right, you have this overhang curve. And this has been described very well in the Harm study group by Peter Newton's group, looking at the L4 tilt. If it's tilted to the left, it's a 1AL subtype. If it's tilted to the right, it's a 1AR subtype. The main difference between these two curves is how distal you have to go in the 1AR subtype on the right, because the last touch vertebra is more distal. And if you look at the distribution of these Lenke 1A subtypes, the right-sided curves need a longer fusion, and they're more analogous to the King type 4. So many times you might have to go to L2 rather than L1 or T12. This is such a curve. This is in a 14-year-old boy. I've drawn the center sacral line. It barely touches L2. It's more substantially touched by L3. Unfortunately, in a thoracic curve pattern, sometimes you do have to go to L3 to get proper truncal balance and avoid add-on. Now, a word about the upper thoracic curve. Which ones are structural? Both ones that are rigid and kyphotic. But what about if they're in between and you're worried about shoulder balance? You're probably better off on including those curves. And the same thing happens in lumbar curve patterns where you have a large proximal thoracic curve or main thoracic curve that doesn't bend out. You're probably better off including that curve to keep the trunk and shoulders balanced. And as was mentioned before, simple rules for the upper instrumented vertebra, which the classification system doesn't talk about, but we've grown to accept somewhat standard. In the type 2 curve or double thoracic, go to T2. If the right shoulder is up, you're better off stopping at T4 so you can get the right shoulder to meet the left. If the shoulders are level, consider T3. And if the left shoulder is up, such as in this patient, and the proximal thoracic curve is 35 degrees or greater, described by Sook, then go to T2. So in summary, the classification system only suggests the region of the curves needing fusion. You have to look at the patient, not just the X-ray. Lumbar prominence is larger, then by all means include the lumbar curve, especially if they're decompensated to the left or have a deep lumbar crease. They're not going to be happy with a selective thoracic fusion because of persistent trunk shift or waistline asymmetry. With a high left shoulder, include that proximal thoracic curve. And most of all, and I think with Indian patients, this is much more common because they're presenting with large main thoracic curves more commonly. You may want to include that proximal thoracic curve because you're doing such a substantial correction that it's going to drive the left shoulder up. And when in doubt, fuse that extra level if the patient is young or the surgeon is young, obviously to avoid lumbar add-on. What's missing in all of this? I think the 3D comprehension of AIS is moving forward with EOS imaging. We have to define 3D goals of treatment, evaluate those results in 3D, which we're doing now, and be more reliable about the AIS classification. I think Peter's talk on selective thoracic fusion is going to encompass a lot of these 3D principles, so I don't want to steal his thunder, but the SRS 3D classification committee is working hard in order to look at how this can be involved in 3D. For instance, this is a similar curve pattern in the main thoracic curve, but the kyphosis in the proximal thoracic curve is quite different. So that would prescribe 2 different treatments for the same type of curve when looking at 3D, which otherwise in 2D may have been missed. So in summary, the Lenke classification system only guides us as to which curves to fuse, not the end vertebra, not the specific levels. The lumbar modifier may not describe distinctly what curve type you're talking about. The 25-degree side bending criterion is loosely defined as structural because it's quite arbitrary, as we've noted before, and we end up breaking the rules about 15% of the time. I hope I've highlighted some 1A curve types that really need to be reminded because you don't want to get burned on those overhang curves. Thank you very much.
Rajan, you want to lead this discussion?
It was a beautiful lecture as always from Sukan. He's so thoroughly grounded in adults and idiopathic scoliosis. But I wanted to ask the question to Sukan. What does he think of the traction film in making decisions about the lower end vertebra for your instrumentation? Also putting the patient on the table on traction and then taking an AP view to see where you can try to save one more level. Does that work for him? Because we have tried to do that sometimes, fuse a level short.
Yeah, great question, Sajan. I think Azmi from Turkey is probably the first one to describe that traction anesthesia film, and I think it's worked very well for those patients. I think what we have to remember is 2 things. Biomechanically, traction films are better than side bending films when the curve exceeds 75 degrees, and that was showed by Punjabi and White. And I think in large curves, that's a very effective technique. But I would caution to not do that technique in young patients, because younger patients are going to have more flexibility on that traction film. And if you get driven up one level and they tend to grow and add on below, that is one pitfall. So in a mature patient, say 14, 15 years old or older, I would say that's a great technique and sometimes will highlight an opportunity to save a level. But in a younger patient, you're better off just acting on the standing film and not the traction film under anesthesia. That's my personal view.
Thank you, Sukan.
Because the ones who the most on the traction film are the neuromusculars, who actually you need to go further down because they are so flexible and correcting.
Yeah.
But I have one more question, Sukan. And of course, this is my bias showing because for the last 2.5 years, you have visited Chennai and you have seen us doing non-fusion deformity corrections. And of course, I am involved with the European group to come with a new classification for what works well for non-fusion. Do you think at some point Lenke would be able to incorporate this, or whether we would have to have a different classification, Sukat?
Well, I think we can use some of the principles of Lenke to non-fusion, but one of the pitfalls that I highlighted on that list is age and skeletal maturity, which can drastically affect what happens with growth modulation. For instance, what we're knowing now is that the Sanders 2 patient, or the patient prior to peak height velocity, is one that tends to overcorrect with non-fusion or tethering, whereas the Sanders 3 or Sanders 4 is a very reliable patient to prescribe growth modulation. So if we can take into some of the structural characteristics and provide an age modifier or skeletal maturity modifier, I think you're onto something there. So a combination of multiple factors would be important.
Yeah.
One last question, Suken, one last question. The Lenke 5s, I have always been unhappy fixing them sometimes to L5 and of course into the thoracic spine. Are you looking at, I am looking seriously at non-fusion for these patients. What is your view on that?
Yeah, I think that the thoracic curves are easier for MIS techniques because we can get the lung out of the way. The thorax is a nice space to operate in thoracoscopically. If lumbar tethering can get to the MIS arena, then it has a real future. We really want to think about preserving motion in the lumbar spine. I think that it has to be a minimally invasive technique to be better than a short segment fusion. So we have to get away from non-inferiority. If we want growth modulation to have a future, it has to be superior to our current techniques.
So do you think it's in or you think it's out, Suken? And I would like Dr. Newton's comments also, whether tether for a Lenke 5 is in or out today.
Tethering, is that what you said?
For a Lenke 5, do you think tether is in or tether is out today, with today's data?
I think it's maturing to determine whether or not it has a role. It's certainly been the minority of cases in the series that we've collected within the harm study group. I think it's really a very small minority of the cases. However, as Suken mentioned, I think that's where the money is. I mean, that's where the motion is. That's where we'd really like to be preserving function and motion. So I love the concept that it is the best area from that standpoint, worth the most if you can do it. I think the challenges are greater there. The motion is greater, the growth is greater, the approach is not as straightforward, the revisions may be just as difficult. So I guess I still have some concerns. I know some folks have tried to manage the tether breakage problem by putting in 2 cords. You know, if you put in 2 cords, your rotational motion has been reduced by having these 2 cords, and exactly how much motion you're preserving is harder to know. So I don't know if that's exactly going to be our best solution there, but I would like to think that with advancing technology and implant development that we could overcome some of those. But to Suken's point and Sanjan's question about, you know, the growth is just so much more of the question, I think. And if we're going to, at least I still don't believe that we're going to have an option to do this in patients who are mature. I don't think that we're going to find an implant that's going to be durable enough to last 30 or 40 years. I just think that's a real long shot. But if we can predict growth better, then maybe we can be much more predictable. And it's true that the Sanders 2 patients have far more growth than the Sanders 3 patients. And growth right now being so difficult to predict makes it really hard in those patients. But I would also say that those are the ones that have the most growth potential, that if we can sort out the growth and predict in what curve size at what age the surgery should be done, I think we have really great potential in these younger patients to correct much bigger deformities that are and much more completely.
Thank you, Dr. Newton. Thank you, Dr. Suken, for a wonderful presentation. And thank you, Sarjan sir. I think because of time constraint, we'll have to move on to the next topic on adult deformity. We'd like Dr. Ajay Joshi from Texas to share his screen. Over to you, Ajay. As we all talk about deformity, but in common practice with a lot of orthopedic and spine surgeons, adult deformity is picking up big time because there are a lot of challenges. Whether to decompress, whether to do only deformity correction and things like that. Therefore, we wanted to get some inputs and know better than Ajay for this. Over to you, Ajay.
Hey, good morning or good evening, and thank you very much. Let me get to the start here. So, lot to cover here. It dovetails into Dr. Lamb's talk as well, which was excellent. Sagittal balance, essentially where should we be in space, has been very well studied as of late. Matching curves obviously put us in an upright position, and the challenge is to stay there as we age. And most of us are familiar with these parameters. They have really been a fundamental breakthrough in understanding the spine. The sagittal plane is certainly the most important in its correlation with quality of life and function. Coronal imbalance is much better tolerated. The global balance summary is shown here. We've been over this earlier. I won't belabor it. The compensatory mechanisms can be very hard to sustain, and that leads to the pain and dysfunction. Changes can happen over time. If you look at the discs as obviously structures that wear, and as they do wear, we can lose lumbar lordosis. So the X-ray on the left shows that and shows the global imbalance. It may be that there's something like trauma that suddenly changes balance, and that becomes a clinical problem increasingly over time. So the techniques that are used more or less by the community of surgeons addressing these problems include these shown here. Standard implants can add a little bit of lordosis, especially when we compress behind them or do a formal Smith-Peterson osteotomy. Hyperlordotic implants have been incredibly helpful with anterior column release, as Dr. Lan alluded to. PSO and VCR are different and powerful techniques, obviously working through resection of bone, not adding length in the anterior column. And finally, something that I have found to be very helpful and may be appropriate where technology constrains us from having access to certain platforms like direct lateral is TFAR, or transforaminal anterior release. Deformity obviously is either flexible or rigid or somewhere in between, and that can affect our strategy. Examples, obviously, a previous fusion, whether it fused or not, is rigid, and adjacent segments tend to be somewhere in between. So implants are shown here. You have standard cages that can be a lesser amount of lordosis, and these hyperlordotic options are often 20 or 30 degrees to be used with anterior column resection. Osteotomies are shown here, and the top one is a Smith-Peterson or posterior column resection to be done with an anterior column release if the deformity is rigid, and if there's more of a flexible deformity, then certainly rigid fixation, Smith-Peterson osteotomy, bone grafting, potentially bracing as an adjunct could be very successful. Pedicle subtraction is more extensive, shown below. Obviously a 3-column correction, more powerful correction, but more potential for problems intraoperatively and postoperatively. A VCR is shown here, and that is really resetting the spine in a correct position. Principles including shortening appropriately, rigid fixation during, above and below, most potential for neurologic issues and bleeding and instability. Anterior column resection was discussed earlier and has been very helpful for achieving correction. The platforms for direct lateral often have a technology intensive and proprietary element of nerve hunting or the retractor allowing minimally invasive access. And if that's not accessible in certain settings, we'll talk about a variation of this, which is very helpful in my opinion, which is the TFAR shortly. But the ACR is basically a lateral approach, or anterolateral in the case of OLIF, just a variation on the theme, soft tissue resection, and resection of basically 240 degrees or 200 or slightly more of the annulus and nucleus, allowing hinging open on the PLL. Transforaminal anterior release is shown here, described and developed by Fred Sweet, an American surgeon, with the notion that you can do the same sort of release anteriorly, but from a posterior approach. So you essentially start with PLIF or TLIF access and discectomy from bilaterally, a Smith-Peterson osteotomy. And then if you look at the diagram of the exiting nerve root, if you protect that nerve root with something like a Penfield, you slide a knife down the lateral annulus to release it, and then your anterior release under a microscope is kerrison bites from side to side that accomplish a safe release of that ALL, after which you're ready to position that segment into more lordosis, putting a cage in. The typical cages we have are not designed for this, but standard PLIF, TLIF cages can be positioned very nicely, and under compression, they will rest in a stable fashion in the posterior aspect of the interbody space, and then a lot of bone graft is packed in. Cases to show include situation of a previous L5S1 PLIF and adjacent segment degeneration with slippage at L4-5, parameters as shown, pre and post-op, direct lateral anterior column release with the hyperlordotic cage, leading to very good function at a year out. Case 2, previous surgery that was 2-level L4 to S1, not achieving a lot of lordosis, broken screws at S1, but ultimately she had fused there, and an adjacent segment instability, spondylolisthesis, degeneration, and working harder at L1-2 and to achieve being upright, but a positive sagittal balance. The strategy here was extending up 3 levels, a standard interbody through a direct lateral at L1-2, a hyperlordotic at L3-4, as that's what was measured and mapped and planned to give her overall lordosis closer to her pelvic incidence. Case 3, similar strategy, similar problem, 2-level, prior 2-level fusion, had fused, but he was in quite a bit of pain. Positive sagittal vertical axis, not really a mismatch of pelvic incidence and lumbar lordosis, extended him up 4 levels, and he was quite happy afterwards. This is the earlier X-ray with multiple levels end-stage degeneration in the lumbar spine. Lumbar lordosis is quite low. Sagittal axis is elevated significantly. So the sequence was interesting. It was, and really underscores that sequential work will not overload the team or the patient, and is very appropriate, especially when working through some less invasive aspects that are not nearly as stressful. So stage 1 here was ALIF at L5S1 on a different date, 2-level hyperlordotic, L2-3 and L3-4 with 20-degree implants, anterior column release. And then stage 3 was a traditional open procedure from T11 to S1 with pelvic fixation as well. Clinically very satisfied several years out. Last case is significant sagittal imbalance, not a large pelvic tilt, but clearly a mismatch between lumbar lordosis and pelvic incidence. This was a longer fusion, open traditional approach. And she did develop some PJK, tolerated this. She's been quite active and went on to a solid fusion and very satisfied with her result. So the summary is that objective spinal analysis has really helped with the thoughtful surgical strategy and projecting a successful outcome and the ability to execute and arrive at that outcome. The right films are obviously critical. The parameters are now well known, and they correlate, especially in the sagittal plane, with a successful outcome and well-being. The techniques are shown, and I think, again, ACR was covered well earlier. What I would say is that for those who do not have ready access to the platforms that include the nerve monitoring, the hunting, the nerve hunting rather, and the minimally invasive retractors, which make it appealing with less morbidity, consider the TFAR as a very safe approach, which allows significant deformity correction, especially in a simple uniplanar sagittal deformity, but from all posteriorly. Thank you.
Yeah, great talk, Ajay. Excellent demonstration and explanation about a few cases. I would like to ask Rohit, in Indian scenario, when we practice, the demands are quite extensively different at times. How do you approach this degenerative adult deformity when they come to you? What all are the important parameters when they come to you, Rohit?
Yeah, so let me just understand the question again, Shailesh. Your question to me is in terms of patient, like how do we decide which patient gets how much or how much intervention is there? Yes. So I recall, instructions that I had when I was a fellow, where one of my teachers had said that less is more in these kind of patients, and especially in a scenario where we don't have access to a lot of insurance cover, and most patients hesitate to go in for big surgeries. I think the trick is really to try and see how short we can keep fusion levels, and how minimally invasive our work can be, especially decompression. I think decompression is the trick. Try to keep the surgery as short as possible.
Okay.
Optimally.
Yeah. Ajay,
can I make a comment?
Yes.
So I think adult deformity understanding is still very much in its infancy. I see a lot of patients who undergo rather, without any scientific basis, multiple level fixation, maybe an occasional interbody fixation, without too much understanding of what the sagittal parameters should be. I think, first of all, this surgery should be offered to a very limited and focused group of patients who are really disabled. And also, we have to remember that our Indian patients, older patients, accept deformity much more comfortably because of the support of the family and everything. They are able to live reasonably well with fair amount of deformity. So we need to offer it to a very small percentage of what we are dealing with and we should deal with. The newer techniques like minimal invasive anterior OLIF or lateral procedures, as well as robotic surgery, will make a big difference in this.
Okay, Ajay, in your practice, when the patient comes to you, and yes, you are always worried about this deformity with adjacent segment and collapse, PJK, DJK, all this. But if a patient is with mainly leg symptoms, and there is a elderly patient, 70, 75, it's an auto-stabilized spine, how will you approach this patient? Not much of a back pain, but mainly stenotic symptoms.
Sure, mainly stenotic symptoms, and if you think that the spine will remain stable with the decompression that you think will address the leg symptoms, I think it's very appropriate to emphasize decompression only. Now, if you're decompressing and you create instability, that's a different matter. I think the other issue to be said is that these sagittal balance parameters, the normative for you and me is different than normative for 70-year-old, 80-year-old. So the T1 pelvic angle, the lumbar lordosis or PI minus LL, I think for an older person, you're okay with them leaning forward a little bit. They need to see the floor. They need to see what's in front of them, fall risk mitigation. So yeah, I think it's appropriate to say, I don't see overt segmental instability. I don't see a dominant back pain. I think it's okay to emphasize, decompression.
Okay. Yes, last quick comment from Yogesh, and then we move on to Dr. Surya Prakash.
Dr. Ajay, just one small comment. I don't actually do the PFAR technique the way you described, but I just wanted your comment. What do I generally use? I do an all posterior approach, but I use a screw-based distractor at the apex where I want to release on the concave side. And I just do the standard procedure of, using a paddle distractor inside and trying to open up the concavity at the apex. And that has generally given a fairly satisfactory correction of the coronal balance. And also, of course, when necessary, I just put a unilateral, bullet cage on the concavity so as to jack up the space. Just wanted your comment on that.
I think that's excellent and appropriate. Excellent and appropriate, and I appreciate that. That's good. I'm simply suggesting that the ability to get anterior and to safely work across, even with the vessels that are, a centimeter away, with careful pre-op imaging and planning and good technique, lets you manipulate that spine significantly. It's just another tool in the toolbox. And I think that in a resource-challenged population, especially, you're not talking about fancy implants like the NuVasive implants that are hyperlordotic. You're talking about standard cages that could be, your cost-effective implants that are positioned in that posterior aspect of the disc space. So when you have significant sagittal imbalance, and of course, you don't have standard resources like blood banks. I don't know about cell saver frequency, but it's a less bloody, less expensive way to accomplish significant sagittal correction when needed. But what you describe, I think, is very appropriate. It's a overlapping aspect of this deformity correction.
Thank you, Ajay, for a 360-degree view on adult deformity. As it's a very challenging field, and the patient selection is the key. There is significant imbalance, instability, back pain, difficulty to stand and walk, sitting pain. All these parameters really are into the consideration, along with the sagittal imbalance. And that's the topic which we wanted to know from you, and you executed it very well. Thank you for being there, Ajay. We move on to Dr. Surya Prakash Rao, and the topic is very, very important for all of us: issues, problems, and adverse events in deformity surgery. And none other than Surya Prakash Rao for this wonderful talk.
All right. Thank you, Sailesh, for giving me this beautiful opportunity. A great evening with beautiful interaction with stalwarts in spine surgery. Well, already I'm learning a lot. And these issues, problems, and adverse events in scoliosis surgery basically are very peculiar to our scenarios rather than in Western scenarios, because most of the times here we work with some resource crunch, and then I'm sure most of us will understand this. In this more short lecture, I would like to say that all these are continuum of care for spinal deformity patient before, during, and after surgery. We will review the situation with clinical examples, and I would like to keep my talk short just by showing few pictures and few points. See, issues, problems, adverse event can prop up preoperatively, intraoperatively, and postoperatively. Well, in postoperative, there can be immediate or delayed. But we do not really focus much on delayed because they are all covered under complications, issues of a totally different scenario. Now here, preoperatively, most of the times we get a patient with severe restrictive lung disease. And as usual, around curves less than say 70, 80, 90 degrees usually do not pose much problems. But any curve which is greater than 100 degrees always has a lung compliance issue. And I have used this incentive spirometer as a very good means of optimizing the patient preoperatively. I'm sure a lot of you guys use it, because sometimes I tell the patients that unless you lift all these 3 balls in inspiration, I will not sort of take you up for surgery. So it sort of takes them a sort of an incentive for them to do. Though we do pulmonary function tests, because pulmonary function tests do take a lot of learning curve. So many times the outcomes are not really so great, but I find this simple clinical tool extremely useful in the preoperative setting. Well, we need to look for cardiac comorbidities, especially when you are handling levels keep falling down as you put pressure, as you correct and manipulate the spine for deformity correction. Then there can be septal defects, and whenever there is impending carpulmonary or pulmonary hypertension, these patients need to be evaluated very deeply before you contemplate any intervention. Urogenital anomalies, especially when you are planning an anterior surgery, sometimes there can be a pelvic kidney. All these things need to be sorted out. Most of the times in the MRI, we get to know. And especially when treating these neuromuscular conditions, cerebral palsy, they have very poor nutrition. Sometimes gastrostomy is really important to improve their nutritional status before we contemplate intervention. Let us take through a few intraoperative steps, which can become issues on and off. Well, positioning of the patient is extremely important. Improperly positioned patient with pressure over the eyes can lead to blindness. Improperly positioned shoulders, especially if the shoulder kept in hyperabducted position can lead to brachial plexus lesions, pressure on the face, sores on the face and nose. Then, of course, placement of electrodes is really important, because sometimes once you place the electrodes in a little bit abnormal manner, and once you position the patient, it becomes a hell of a lot of a problem to unhook and rehook those electrodes back into the patient. And endotracheal intubation, a bit on it later. Urinary catheterization, also I will talk about it later. Then surgical exposure and imaging. Well, that's really important, and a good exposure really reduces the intraoperative blood loss, and it is extremely useful. Well, we have to then place the implants and anchors in a very safe manner without injuring the neural structures, and they should have good purchase onto the bone. Then we will do the intraoperative manipulation and corrective maneuvers. Coming to patient positioning, most of the times this job is relegated to the junior most, who is inside the OR trying to position the patient, and then the seniors walk in. Use of special tables are there, but then in our scenario, we don't get to that. We need to protect the eyes and face. And well, there could be some surgeons who would prefer a horizontal bolsters versus longitudinally placed bolsters. But for me, I generally prefer to do a horizontal bolster, positions of the arm and neck. And let's take into special situations where positioning is going to be a real nightmare. Like, look at this patient with an ankylosing spondylitis, completely fused thoracolumbar spine. Fortunately, he has got good neck movement. And then when we make him lie down prone, this is how he is. And then to place him is a big challenge. So for that, we probably have to break the table almost to the tune of 40 to 50 degrees, and we have to place the bolsters. Maybe distal bolster has got some anchor, but the proximal bolsters are not so good. It's only after the deformity correction, he lands properly on the bolsters. Now look at this situation. In an Anderson lesion which has been mistreated by somebody else, the patient presented to us a chin-on-chest deformity which has been happening for the last 4 to 5 months. Now this gentleman, this looks like a mediastinal mass here. You look at the MRI scan, you look at the CT scan here. It's almost impossible to sort of position him. He's like this. Now, when this chap wanted correction and then he could not tolerate any amount of traction, we actually thought how to place him on a table to do the osteotomy. Then we requested one of our attendants, OT attendants, to lie down on the table with the chin tucked over to the chest. And then we experimented with him. Then we finally could position him. And of course, intubation is a big nightmare. You can see a team of anesthetists were there trying to help us to intubate on him. And then it almost took from 8 o'clock when we started, we could intubate only him 11:30. And then positioning is a big challenge. As you see, it's been almost no imaging was possible, and it's been extremely difficult. Lot of what do you call it, improvisation and local innovations were to be done. And this is after we have corrected the deformity. So again, in such patients, extubation is really a challenge, because suppose if these chaps do not really, breathe well afterwards, we have to have a tracheostomy ready, because preoperatively tracheostomy was not possible because of chin on chest deformity. Well, in this case, we could get a very good alignment. Now, coming to urinary catheterization, it's a very unassuming routine step, but then suddenly, you have the complaints from the OR team that, look, we are not able to pass the catheter. Many times there is a urethral stricture, there could be phimosis, and then especially, I'm sure Shailesh will understand, he will be operating a lot of people from Middle East and those countries where females are subjected to this inhuman female circumcision, where it becomes really impossible to locate the urethra to pass the catheter in. And it's a nightmare to do an operation like this in prone position without bladder drainage. So for some situations like this, it's always better to have the OT nurse look up this patient beforehand, and if they see any issue, get a urologist consultation before taking him into the OR. Of course, intraoperative blood loss, lot will be talked about this in any conference, where the use of good plane of anesthesia, use of hypotension, use of agents like tranexamic acid, and obviously nothing goes beyond a good surgical technique. Well, intraoperative placement of implants, of course, use of a C-arm. Most of us use C-arm to know the levels and to check our positioning. Well, if you are rich enough, you can use your robot, you can use your ISO C-arm, O-arm. And it's very peculiar to see a lot of us among surgeons who are earlier very, very good with the freehand placement of the implants. Once they buy the latest equipment, they tend to switch over to that in terms of patient safety. Well, we have to take care of these extrapedicular techniques for placement of screws in areas where pedicles are dysplastic. And mind you, these extrapedicular screws are actually as good. Coming to neuromonitoring, well, placement of electrodes and hooking them up is really important. But it is really good for the people who have got a dedicated neuromonitoring team. But say in a setup like us, it is me, myself, and my team who does the neuromonitoring. We don't have a dedicated neurophysician to come and help us because he feels it's not worthy of his time. However, we try to convince him. So then we sometimes reuse the electrodes, and then, well, of course, we use the surgeon-directed method. And of course, here the most important is to ask the anesthetist to use the bite block. So whenever you give the transcranial stimulation, there is a strong contraction of the teeth and tongue, so that you can save the tongue. And of course, number of channels. And we are restricted to 4 channels. A neurophysiologist team can have a lot of channels, and then they probably can do a better monitoring. But then what should we do on signals and vanish? I think a lot of material has been done on it. I wouldn't try to dwell on it because that actually needs a separate presentation as such. Now, just to show an example, a severe kyphotic patient, before correction, waveforms are all good. And after vertebral column resection, one side we have found the tibialis anterior is not showing up. When we checked up, we found there is a fragment on the right side. We removed the fragment, and after a while, the wave pulsations got up. That way, neuromonitoring extremely impossible. Extremely useful to to know these problems, and we can correct the deformity at the same time, make the patient fairly safe about it. Then immediate postoperatively, there can be sometimes neurological deterioration. Well, in such situations, I think it is really important to check up the blood pressure status, and whenever possible, the patient should be shifted into a CT scanner to find out the positioning of the implants, which is extremely important. Sometimes during the correction maneuver or later, the positioning of the implants may change, and then they may cause neurological issues. And then, of course, there are issues with prolonged surgery, like need for overnight ventilatory support. We need to replace the lost blood. Then there can be pulmonary complications, effusion, atelectasis. So as you prime the patient with a incentive spirometer before surgery, as soon as the patient is awake, we tend to encourage him to do that, because as the patient does that, usually lung gets expanded well, and then there is no problem. Well, fluid management is extremely important. Sometimes excess fluid is given. You see the patient next day morning with the puffiness of face, and sometimes inadequate fluid management can lead to loss in the volume of the urine output. So all this needs to be taken care of. Coming a word about thoracoplasty, a lot of surgeons who do the thoracoplasty, many times when more ribs like this are resected, it is very important to put an intercostal drain, because though we feel put a fluid and check for any of the leak. Sometimes still there can be some form of a effusion because of the sympathetic nature. So in my practice, whenever such an extensive thoracoplasty is required, I always put an ICD, and that is actually saved the day, because otherwise you will be called in the middle of the night as the patient complains of breathlessness. Now even this patient, even with such an extensive resuscitation, everything falls back, and after 6 months to 1 year, everything is real normal. But it is important to avoid such complications at this point in time. Well, post-operative infections, especially when we have a thin soft tissue cover on the patient and we put bulky implants, there can be a problem, and that can lead to exposed implants that can be used to implant failure, pseudoarthrosis. And some clinical cases here, you can see such a severe deformity like this. I think in such cases, especially where the entire thoracic spine is there into the deformity, it's to take up this case would be an extremely challenging. We may even risk the patient, as the patient has hardly any lung reserve. Maybe these cases are for preoperative halopelvic or halogravity traction, and then later manage the patient. This is one patient who has got a very severe curve, which we have got a decent correction with instrumentation. And unfortunately, what happened is she had some implant prominence, for which a small plastic surgery we had to do later. But then the patient went home and then came up with this severe issue. And to salvage this condition, we had no other choice but to remove the implants and then sort of closure. But fortunately, the entire duration freedom to here took around 1.5 years. So it was spinal deformity was reasonably consolidated. And that is what happened. Now, before going into further cases, I would like to ask Shailesh, if I have time, I'll go ahead. Otherwise, I can stop here for the want of time.
Show this last case and then we can stop here.
Yeah, thank you, Shailesh. This is about a 20-year-old boy with a congenital thoracic scoliosis and panhypopituitarism, had a sudden growth spurt with spastic paraparesis. If you can see here, very innocuous sort of a curve here, and then which was there in 2003, very mild curve. And usually we do not expect a neurological compromise with such a small kyphosis. But if you see here, almost the spinal cord is crushed to the concave pedicule. And this is one part which is really important, because sometimes we should always see exactly what is the cause, and then it is very important that we should image and look for this problem. Otherwise, we will miss. And of course, this chap has done reasonably well with concave pedicle resection and then moderate correction, instrumentation, and fusion. Thank you, Saresh.
Great talk and excellent demonstration of small inputs for issues, problems to all of us, and a lot of learning from your talk, Dr. Rao. I just would like to ask you, with your experience, how much time you really give to such patient when you're planning for surgery, how much you talk to them regarding problems, issues, complications before you pose them for surgery?
I think that's a very, very important question, Shailesh. I think we have to spend a lot of time in talking to these patients. In fact, sometimes it takes about half an hour to 1 hour trying to explain. The sad or the very interesting part of the entire story is once you explain a particular concept to the patient in the first 10 minutes, and then you take them through the entire course in the next 30 minutes, and suddenly when you think it is time to conclude, they come back with the first question as if they have not understood anything what you have said in the first 10 minutes. This is the real common problem which I face. But then the problem is, what I understand from patients' perspective is that they are also very stressed and tensed. So though we as surgeons have seen many cases, it is for them their only child or an only boy who is undergoing surgery. So they are always preoccupied. First is obviously about the hospital bill, and second thing is, okay, we are handing over this boy to this doctor, what he will do. They keep, they seem to be understanding initially, but later on, suddenly they withdraw. So I think the most important thing is that we should have patience and trying to simplify our talk to them. And we should always tell them in a language how they understand, more than trying to show off our scientific jargon. Right. That is what I've learned.
Yeah, perfect. Dr. Rao, the way you said it, absolutely, I completely agree. And one last question I would like to ask you, what all, see, we don't want to ask about any OARM, robotic, but for general, we all use freehand techniques. So what all are the rescue tips from your side? I've seen in one of the cases where you use the sublaminar wires, hooks, all these things, whether it is important to keep all these things before we plan for surgery to avoid problems on table.
What I always do is keep a stainless steel wire set ready and a wire instruments always ready with me in the OT 24/7. So that set is always there. So whenever I feel that I'm losing control, sometimes, especially many times in scoliosis surgery in younger people or in poor proximal thoracic, situations where screws you may not really get a hold, and then I try an extrapedicular technique. If that also doesn't work, then we go back to hooks and sublaminar wires. I think it's in a scoliosis set, irrespective of what our ego says, we must always have hooks ready. And in an OT theater, we should always keep sublaminar wires ready because anyway, orthopedic team, we are a part of an orthopedic team. They always have wires available with them. So, but then more than that, I prefer Synthes, the soft worked wires, which are far useful than that prefixed wires. If you already have pre-contoured Drummond wires, I mean, there's nothing like it. I mean, you can always just use them.
Point well taken, and there are a lot of things which we can ask, but in view of time constraint, we'll have to move on for the next topic. Thank you, Dr. Rao, for a wonderful presentation, and over to you, Rajan sir, for anterior scoliosis correction. Yeah, Dr. Hegde.
You need to unmute yourself.
Yeah. So I think I can't think of many people, but at least definitely my elder brother in the profession, Arvind, Dr. Arvind Jaiswal, and I have always been interested in anterior deformity correction. And it was easy for me to segue from anterior deformity correction to look at a totally new way of looking at deformity correction, that is non-fusion anterior scoliosis correction. So I'll just start. Yeah. So let me start right at the beginning. You know, my influences were the Franco-German. I worked in Institute Callot with Dr. Yves Cottrell and Dr. Daniel Chopin at this wonderful institute. And I learned all about posterior instrumentation and correction. But it was my time that I spent with Dr. Jürgen Harms that took me away into a new area, that is anterior deformity correction. Of course, we are all familiar with the Harrington rod instrumentation, which was the gold standard before I started doing instrumentation. For about 50 years, this was what was talked about, and everybody thought that this was the only way one could correct spinal deformity, and anything else would not work. So when I presented, of course, when I did the first CD instrumentation, the Cottrell Dubusse instrumentation, and presented it, it was met with a lot of pushback and people did not accept it. But we know that Harrington instrumentation had its issues, sagittal imbalance issues, which led to an entire generation of spine surgeons in the last decade who were busy correcting all these Harrington rods that had been fixed up to L3. So for us, early surgeons, tuberculosis of the spine gave us a view of the anterior spine like nothing else. It was a great teacher. It helped us expose the anterior part of the spine. We were all very comfortable and familiar. And my time that I spent with Professor Jürgen Harms strengthened that belief, and to be able to do anterior deformity correction. though it of course lost popularity in the last 2 or 3 decades, we know that in certain situations, it is the best option. And like you see in this boy with the thoracic major, as well as a lumbar structural, and also it is a triple deformity, as you can see here. But the acute deformity is in the thoracic spine. So if you were to do it from the posterior side, you would do from maybe D2 to L4 and do PSOs, and you would perhaps have a blood loss of almost 1,500 ml trying to correct it. But we did it from the front, and we selectively have fixed only the most rigid part of the deformity. And you can see how the upper part as well as the lower part of the spine has spontaneously corrected. And not only lumbar levels are saved, the blood loss is less than 400 ml in this surgery. So this is where I come from. And I was very familiar with anterior deformity surgery. And, you know, when you do a correction like this, you have fused, you have given the patient an ankylosed spine, except maybe for one level at the bottom. We do not know what the long-term consequences of this kind of surgery will be. So I was looking at something else which would satisfy me in certain patients. And that is when I started looking at anterior scoliosis correction using a polyethylene terephthalate cable fixed on the anterior vertebral screws and correcting. Initially, of course, it was growth modulation for younger patients. For example, like this child who was perimenarchal, Risser 0, Sanders 4, she still had some growth left. And this is how we corrected her from the front. You can see in this that we have intentionally left some degree of deformity. And at 2 years, you can see, not at 2 years follow-up, her deformity is perfectly corrected, and you can see her posterior clinical picture showing a perfect leveled shoulders, perfect correction, and the flanks absolutely symmetrical. So this is what growth modulation was all about. And of course, as I asked Sukin earlier on, that maybe there will be a newer classification as non-fusion becomes more and more popular. Perhaps we will have to move away from the classical Lenke classification to decide which of the deformities are ideal for non-fusion correction. And of course, the younger group will be the ideal group in which to correct this deformity. But also, look at these 2 children. Here you have a child with a classical Lenke 5, and we have corrected. Now, if we had done it all from the back, we would not only be stripping the posterior lumbar musculature, but also fusing her perhaps from L5 to D10. And this is what we have done. And her sister, who is 14 years old with a similar deformity, has also an anterior scoliosis. Or as Peter said, only time will tell us whether this stands the test of time, and we will know whether it works. Now this child, 13-year-old, has a very severe, Cobb's angle measures 80 degrees. She has a Lenke type 5. Her lumbar spine is, the deformity is extremely severe, rotated. And also you have to see that she has an incidental spondylolisthesis at L5S1. Now, if you were to do the standard posterior instrumentation, you would definitely have to go into the sacrum and fix her up to D10, which means you are taking away her mobile lumbar spine is now fixed and rigid. And this child was very keen that she would like to do yoga and Bharatanatyam. So we decided for an out-of-the-box option. We have done an anterior scoliosis correction of only the rigid part, that is the lumbar spine. This is how she looks before surgery, and this is how she looks after surgery. And here you see a double curve. Now, Suken showed a couple of them. Now, if you have to fix them from the back, you would fix them maybe from D2 to L4 or L5, which means you have a very, very rigid spine. Now, here we have done an anterior thoracic instrumentation followed by, in the same sitting, a lumbar instrumentation. And we have been able to correct it. This is our 1 year post-surgery, and this has been the result. So whether we will now move towards this direction. Now, I have been looking at other options for unusual situations, like this very young girl, 7.5 years old, born of a consanguineous marriage with a severe progressive deformity. As you can see here, she has the worst form of deformity with a bar on the concave side and hemivertebrae on the convex side. These deformities are malignant. They progress very rapidly. And the classical treatment for this is magnetic rods or growth rods, but they have their own issues, the issues of proximal fixation, the issues of cutouts, and the inability to correct, to have control on the most deformed part, that is the acute deformity of the thoracic spine. This is our MRI showing no cord abnormalities, and a thoracic CT scan is also done showing the hemivertebrae at multiple levels. So the options are bracing, serial cast, growth rods. And what could we offer? This was a child which came before the pandemic to us. We had no idea that we would be running into the pandemic. If we had done the growth rods, they would have had real trouble trying to get back to have the distractions done. So we did an out of the box. This is a clinical picture. As you can see, she is completely decompensated. Her trunk is completely decompensated towards the right, and the deformity is significant. So we did an anterior modulation with the non-fusion technique. This is her before surgery. This is her after surgery. And she sent her pictures recently, and she has an excellent correction. This is a patient who was given to us, the pictures were given to us by Dr. Randy Betts. They have been pushing the limits and even using in adult deformity. Those patients who do not want fusion surgery, they have been, but this may be a little out of the box, a little too much out of the box. We have not offered that kind of thing. And finally, this is a 13-year-old girl with a double curve, the traction film, again, a double correction. This child came to us from Australia. This is her immediately after surgery. And she sent her pictures recently. She is now back to equestrian sport and everything else, and she is leading a normal life. To conclude, these are extremely short-term, earlier results. We have had no breakages. The results have been extremely satisfying, but these are early days, and we will keep you informed as we do more and more cases.
Fantastic, Sajan. You're clearly leading the brigade of modern surgery for scoliosis, and hats off to you for venturing into this space. We are desperately running out of time, but there are two issues that come up. The traditional teaching in scoliosis is you correct and you fuse, and here you're not fusing. So how do you envisage going forwards, rod breakages, cable breakages, etc.? What do you see in the future? Because we are clearly going against one primary principle of scoliosis surgery.
Absolutely fantastic question. When we have rod breakages, for example, in our scoliosis corrections, they manifest with pain and deformity. When you have the cable breakages, often it is unnoticed, but the patient may notice that, may feel that they had a ping or something, they heard some noise. There is usually no further deformation of the spine. You would have to follow it. According to Randy Betts and Dr. Daryl Antonacci, who have a huge experience, a small percentage of these may need a revision, but most may not need any further correction except close follow-up.
Fantastic. The other question, obvious question, is scoliosis is a three-dimensional deformity, and being so, stapling, etc. in the past did not work because it's a uniplanar correction. So how do you think this will go? Because we are practically fusing or correcting only in one plane.
So, Abhay, you were there when we did one of the patients here. So, like when we do anterior fusion surgery, we mobilize, we correct the rotational deformity of the vertebrae as we tighten the cord. So you are correcting the rotation, and as you well know, we can correct the rotation better when we are in the front rather than when we are in the back.
Lovely. So that scores one over the staples and the older methods.
Yes.
Fantastic, Dr. Hegde. So we'll leave this at that because we are massively running behind time. Thanks for that lovely talk. And we'll swing into the other big don from the north, Dr. Shankar Acharya, who's going to talk to us about ankylosing spondylitis and correcting deformities in 10 minutes. And Sajid, if you can unshare your screen so we can have the don link up. And Shankar, it's all yours. Correcting ankylosing deformities in 10 minutes.
Thanks, Abhay. Thanks, Shailesh, for inviting me to this excellent symposium. And I have learned more than anything. Each of these symposium I have attended. And in 10 minutes, I think you asked me to give just an overview of AnkSpons. So I've kept 3 different scenarios. Can you see my screen? No.
Can see it's half and half, but maybe if you go to slideshow, it might get better.
Okay.
Okay.
So I will talk. Shailesh asked me to give a basic brief on this, and so I will quickly go through this. And it's a chronic, as you know, chronic inflammatory disease, occurs in 6 per 10,000 population, and there's an autosomal inheritance in this. And it is a big spectrum from early back pain to deformity. And I would skip all the stages of AnkSpons, but nowadays we know that with new biologics, the treatment is quite good, and you can stop the progression of deformity and ankylosis. And there is a New York criteria and there is a modified criteria, which essentially says that those with back pain for more than 3 months and sacroiliitis or HLA-B27 with any of the SPA features like arthritis, enthesitis, uveitis, dactylitis, psoriasis, irritable bowel disease, etc., fall into this category of ankylosing spondylitis. When do we see patients for surgery as for AnkSpons? So nowadays, a lot of these AnkSpons patients who come early, they are treated by a rheumatologist, and we don't see them much. We see them only when they need surgery or advanced cases. So we have acute fractures which present in AnkSpons. We have semi-acute conditions where you have Anderson lesions or pseudoarthrosis with compression. And then we have late problems with deformity and horizontal gaze and other things. So in acute fractures, this is a standard treatment. You have to do a long fixation and decompress if required. And I don't think there's much to debate here. And they are all 3-column injuries and they may be missed. So it is very important to keep in mind, especially in the cervical or cervical thoracic region. In the semi-acute conditions where you have Anderson lesions, I thought I would show this interesting case. This is a 47-year-old male who came to me from Banaras, and he had a D10-11 extension injury, as you can see, type B hyperextension injury. And he also had a chronic Anderson lesion at L5S1 with severe stenosis. And he was symptomatic, and this injury actually straightened a lot of him on his own. So I would take some comments from the audience and the international faculty as what they would have done. And I showed this case especially for that. And I just did a posterior decompression and fixation at the dorsal-lumbar junction and also at the lumbosacral junction, where I just did a decompression and fixation. This is 6 years down the line. And by just doing that, we had a complete fusion in both the levels. And I asked him to send a picture today. I rang him up and he sent me today's picture. So he is comfortable and he's not come after the pandemic. So he couldn't send me his x-rays. However, if you go to the literature published and recent studies, in even Bridbell's new book, it says that when you have a pseudoarthrosis and you want to, and there is compression and you want to correct the deformity, it's better to leave the pseudoarthrosis alone and do a SPO distally and correct the deformity. And they have seen, because of the alignment and sagittal balancing, the pseudoarthrosis heals. And that is what is recommended these days. However, most of the pseudoarthrosis patients that we have treated, we have done a standard fixation from posterior, long posterior fixation, as you can see in this patient. And this is around a 60-year-old male with Angstponds, and I fixed him. And this is a 6 years follow-up where complete fusion occurs, though you have not corrected the deformity. But in our scenario, the Indian patients are quite comfortable as long as they have a horizontal gaze and they have no pain and they are able to walk around. The problem is mainly in the late cases with deformity and lack of horizontal gaze. And the deformities can be on the cervical spine, the thoracic spine, the loss of lumbar lordosis, and hip flexion contractures. And that is very important to keep in mind. So in examination of these patients, as Rajan and Surya Prakash said also, that you have to spend time with these patients. You have to counsel them what you can do, what you can't do. And the magnitude of kyphosis, where is the deformity, how many segments are involved, is it a long segment or a short segment, what is the flexibility, and of course, the importance of global balance. This patient is interesting. I operated on him many years ago, almost 15 years ago. He was a tailor by profession, and I made all the mistakes I could. He had a good horizontal gaze, and his neck was fixed in extension, and he also had a lumbar kyphosis, and he was not able to do his profession. So I did a lumbar PSO, and his gaze went up, and he was very, very unhappy. And then I had to do a cervical. I was not very confident of cervical osteotomy, so I did a multi-segment spondylitis in the cervical spine, trying to correct a little, but he was never happy with this surgery. So horizontal gaze is also very important, and per operative, I find it is a challenge when you are correcting these deformities, and it's important to get a tip on those. So clinically, you have to assess them and plan them. Where is the deformity? What will you do and how you will do it? Before you do anything, it's very important to get the nutritional status, so that these patients sometimes can have poor nutrition. Bone density is also important. Respiratory cardiac function is very important. Otherwise, you may land in trouble. And you always must rule out any CV junction anomalies and mouth opening, because that's all very important for intubation. You should encourage smoking, and non-steroidal should be discontinued. Heart checkup should be done, and cervical range of movement, both by anesthetist and surgeon. And of course, nutrition assessment is very, very important. All radiological assessment. Now with the EUS, you need the hip and the whole spine standing. We don't have the US system. So sometimes I do a CT of the whole spine to get better. And you need to measure all the angles, especially the SVA and the kyphosis and the pelvic parameters are important. Where do you do the deformity correction? Preferably the apex of the deformity, which is not always possible when the thoracolumbar in deformity is greater than cervical. Lumbar osteotomy, as you know, is always safer, And I think Samir is talking later on about all the deformity correction and osteotomies. And the cervical osteotomy is to be done very purely for cervical and cervical thoracic deformity, because a lot of time lumbar osteotomy would not solve the problem. For thoracic deformity, still we do a lumbar because it helps, and you want to avoid the spinal cord. And if you can see in a major thoracic deformity, also if you do a lumbar osteotomy or SPO, you can get a good correction. However, in a major cervical deformity, that would not happen. Three other points I wanted to point out in these 10 minutes was pelvic incidence, the hip flexibility, and the position of the sacrum. These are also important to keep in mind, because we sometimes get misled by the ankylosis of the spine and not look at the other things as well. And it's been shown, there are many papers now which show that the incidence of failed sagittal realignment was significantly higher in patients with high pelvic incidence than in patients with low pelvic incidence. So that is important. So patients with a large PI need more lumbar lordosis correction to restore the original sagittal balance. So they may need sometimes two or a skipped osteotomy at different levels. Patients with large preoperative SVA or pelvic incidence show a trend towards failed sagittal realignments. And one level PSOs may not offer adequate correction, and additional osteotomy may be required. The other thing is hip flexion and position of the sacrum must be analyzed. And it is very, very important to check if they have hip flexion deformities, how much they can move, do they have ankylosis of the hip. And sometimes I'm asked patients to go for a hip surgery before you go for a spine surgery. As you can see in this paper, which I was quoting earlier, the one to the left has a large pelvic incidence, smaller pelvic incidence of 39. And with the same correction, with the same kyphosis, they have been able to get good balance, while the one on the right, which has a large pelvic incidence of 60 degrees, they have not been able to get right balance, and the patient is still out of balance. So should you do two-level osteotomies at the same place or at interrupted is always debatable. And they have, this paper from China recommended at two different levels and not at the same level. And also there are newer techniques where you can do a close and open wedge osteotomy, just like this SPO with the fulcrum behind, so that you can get a better correction. And it has been shown that that there's still an angst they can fuse even with an open wedge osteotomy. Careful planning, hence, is the key to accurate restoration of balance, and pre-op analysis is worth the surgeon's time. So calculating all the angles using the SurgiMap software these days is very easy, and you can do. I would just touch upon the osteotomies. The Smith-Peterson osteotomy, as we know is an open wedge osteotomy completely, and there's a risk of aortic rupture and less done these days. Polysegmental wedge osteotomies are very popular. Obviously, these are Ponte osteotomies, easy to do. Of course, in angst patients, they may be difficult because they are all fused, so you have to be careful. And but still, you can get a fair amount of correction if you are worried and you want to, and you are a surgeon with not a lot of experience with SPOs or VCRs. So in this patient, this is a very early series of patients I did, where I just did multiple Ponte's osteotomy, and the patient was happy with this post-op result. PESOs are probably the best for angst patients, and there you can get a good control correction. Of course, when you do, the problem with these osteotomies are sometimes you can get a subluxation, and that is something you should avoid. Or sometimes you may not get the wedge, and you may have a shortening or a compression, and there may be anterior subluxation. So these all things have happened to me, and so you need to be careful with these things. The technique is standard. I think most of you know you have to do a complete laminectomy, then do a pedicle decancellation, and then go to the lateral walls, and then do a lateral wall osteotomy, and then gradually with a temporary rod placed, you have to close the osteotomy and make sure that there is no kinking of cord. And so you may have to extend your laminectomy above and below. The methods, there are three methods of closing the PSOs. You can do a manual reduction by keeping the table, because when you position, as Surya Prakash showed, how you have to position, and then keep the table wedged. And once you have got your reduction, once you've got your temporary rods, you can ask your assistant to open up from the front and hyperlordosis from the back, so you can get a gradual correction. Or you can do a cantilevering, but that's slightly dangerous. Sometimes you get rod pull out in this osteoporotic spine or an hyperextension of the chest and extremities, as I said. However, I do it by changing the position of the table and then also compressing along the nearest pedicle screws. This is a patient in which we did a PSO, and this is the correction we achieved. Thoracic deformities, lumbar osteotomies, as I said, are usually preferred below the cord and the conus level. Large degrees of correction owing to the long lever arm is usually easily done. And so most of us prefer lumbar osteotomies than thoracic osteotomies. Further, thoracic spine being having the chest and stiff fusion, it is difficult to do thoracic osteotomies. And with the same curvature and the shorter distance from the hip to apex, you can have a larger impact on the sagittal correction you can get. Cervical deformity, I think Surya Prakash showed a very good case. It's a severe chest and chin deformity, restriction of forward vision, swallowing, mouth opening, skin care, all these are problems. And it is difficult, dangerous, and you have to be very careful when you attempt these. I personally don't have a major experience on doing chin and chest deformity with such severity. However, the principles are that you need to do screw placements, lateral mass screws or pedicle screws above and below, and then do a laminectomy. At C8 you can do, C7 you can do because the vertebral artery is already bypassed. You identify the C8 root, and then parts of C7 and T1 pedicle are resected, and you can do an extension or a closed wedge osteotomy by applying temporary rods. And Dr. from Nottingham, you have this paper where they have done an extension osteotomy by keeping the anterior part open, and still you got good fusion. Here also manipulation of the head can be done by a halo or a Mayfield frame, and halo is safer. And this paper, they have shown how they have done it. In our experience, wherever we had a hyperextension injury or a compression injury, we have used this technique, but we have just compressed along the rods and left it anteriorly open, and we have managed to get a good outcome because we wanted to play it safe most of the time. So just take home messages, always root out hip pathology. I think that is very important. Whole spine radiographs and detailed evaluation is important. Adequate preoperative workup, careful intraoperative tissue handling, neuromonitoring, and do not overcorrect. I've had a problem with 2 patients where I had overcorrected, even with my small correction, and then there was a problem. Thank you for your attention.
Great talk, Dr. Acharya, and you almost covered the angst, you know, like an exam going, we really went through all the sequence. It's a chalk-stick deformity, and therefore it's preferred to have a long fusion. That's what traditional say. I just would like to ask Siddharth and Ajay, how you will assess if the patient is there with bilateral hip affection and a thoracolumbar deformity. Yes, Siddharth.
So what I feel is if you can get a Thomas's test on a supine couch, and if you feel that there's a 30-degree hip flexion deformity, I'd always involve my arthroplastic colleague, because quite a lot of time this gaze can be corrected if that hip flexion deformity of 30 degrees goes away. Having said this, I would always explain to my patients that it's an ankylosing spondylitis is a disease that involves the joints, including the hip and the spine, and at a later date, it might require a spinal osteotomy, whether it's lumbar or cervical, that needs to be assessed.
Okay.
But most often, if the gaze is quite okay, then most often a lumbar osteotomy is quite enough. Very rarely do you need to go for a cervical osteotomy like Dr. Shankaracharya said, but that's only in a specific case where the chin is actually on the chest.
Okay.
And the gaze cannot be improved even with the lumbar PSO.
Yeah, I would like to ask Ajay, when you are doing such deformity, how important is thoracolumbar deformity? How important is to assess the anterior vascular structures, and how do you take care of it?
I think it's very, 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 very important to assess anterior vascular structures, because I think this is a chronic deformity, and over a period of time, all the vessels, they are contracted. And the moment you do an osteotomy and you extend the spine, the vascular structures are at great risk. So I think what we follow is number one, we really study the vessels and the vascular structures in greatest of the detail, and we also go and study the scans one day prior. And most important part is, as you said, the biggest problem with these things is vascular compromise. So gradual correction, number one, and if at all needed, angiogram also would help in many of the situations. But I think most important part is proper studying the scans pre-surgery. That is very, very, very important.
Okay. Thank you, Ajay. And last, I would like to ask Yogesh. There are some papers which are coming. Traditionally, we always prefer to do a long fusion and things like that, but they're talking about shorter fusion nowadays. What's your take on it? And they think about that spontaneous fusion which occurs in angspond, in fractures or things like that. What's your take on it, Yogesh? You're on mute, Yogesh. You are muted. You need to unmute. Yogesh, you need to unmute. Yeah.
No, I personally have no experience with short segments, but I do pretty much. There is a lot of literature which says that Anderson lesions, generally we need to do an anterior fusion and an anterior cage and things like that. But I have had some few experiences pretty much similar to what Shankaracharya sir showed, wherein no anterior fusion was done and yet the lesions healed. In terms of shorter fusions, I personally don't have any experience in those matters. I still do the traditional longer fusions only.
Okay. Message is clear. Thank you, Dr. Acharya, for a wonderful talk. And we move on to the most awaited talk for today from Dr. Peter Newton, the immediate past president of Scoliosis Research Society. And over to you, Dr. Newton.
Well, thanks, guys. I really appreciate the chance to come and share with you this morning for me, this evening for you, I hear. So happy to do it. You gave me the topic of selective thoracic fusion, and this is something that I've been interested in for a long time. I think we all are. How can we limit the amount of fusion and still get what we need for that spontaneous lumbar curve correction? These are my disclosures. So this is classically the Lenke 1C dilemma. Do we do a selective thoracic fusion hoping that we can get the spontaneous lumbar curve correction that we want, preserving lumbar flexibility, or just go for a more reliable full instrumentation, knowing that we've got fewer lumbar segments left when we're done? I think we're all very familiar with that dilemma. So I think the real trouble here is that we're trying to anticipate this spontaneous lumbar curve correction, and predicting how that will behave has been the challenge. And all of us do this a little bit differently. And so trying to find the exact key to answering that prediction of spontaneous lumbar curve correction, I think, is the tough one. I mean, classically, the Lenke classification has said that if it's a 1C curve, meaning that the C modifier but a lumbar side bending to less than 25 degrees, that these are selective thoracic fusion candidates. Sukin mentioned earlier that this is one of the common areas where folks, quote, break the rules of the Lenke classification and do a non-selective fusion. There's been some reports that some surgeons would fuse this curve, both curves, nearly 80 to 90% of the time, and others in this sort of 1C curve pattern may be down as low as 5 to 10% of the time that they would fuse both curves. So it's quite variability within our own surgical community. Of course, the principles of the Lenke classification are to fuse the structural curve and only the structural curve. There's a fair bit of controversy, I think, about whether we should maximize correction versus minimize the extent of fusion. And those really are sometimes where we're at odds. But clearly, we want to optimize three-dimensional balance. And again, try to predict or guess how the unfused spine will respond. Estimating what happens in the coronal plane is That's probably where we spend most of the time, to be quite honest with you. We're obviously interested in trying to figure out what the shoulder balance will do and what the lumbar curve will do, and in particular what the lumbar, the trunk shift, which is largely dictated by the lumbar response, will do. The criteria in general have been thoracic curves greater than lumbar, and that should be both in the Cobb angle, apical translation, and in rotation. Some of these get pretty close, and you can say, wow, is that really a candidate or not? So the long-term approach that many of us have used coming out of Bridwell and Lenke long ago was this 20% rule. And if you have more than 20% translation, more than 20% larger Cobb angle, the rotation, I got to say, is a little bit hard to put a 20% number on. But in 3D, we're able maybe to get that data a little bit more apparent. And then importantly is the clinical appearance showing more thoracic than lumbar deformity. I think that's an important criteria as well that's not really very well quantifiable. So traditionally we would say if you meet those criteria, we would fuse to the LIV would be the stable vertebra, and that we would do kind of a modest correction and hope to get reasonably good balance postoperatively. And I think that's still not a bad strategy. It doesn't give us quite as much lumbar correction as we can get with some other strategies, but we'll look at that as we progress here. That doesn't always work. In this case, I went to the stable vertebra. Maybe the correction wasn't modest enough. It was a little too straight, and it added on below and just didn't do well at all. So that one almost certainly would have been better fused longer rather than shorter, or having both curves done. Well, we've looked at the harm study group data for a number of years trying to get to some of these questions related to selective thoracic fusion, and identifying this ideal lowest instrumented vertebra was a topic of research years ago, trying to figure out which level would be best. And we queried the database and looked at patients who were fused above stable to the stable vertebra or below the stable vertebra, and then looked at just the main thoracic curve correction and how much spontaneous lumbar curve correction occurred in each of those three groups. And you can see that to the far right, when we fused one below the stable vertebra, we actually had, we achieved in the instrumented segment better main thoracic curve correction, or at least the surgeon did more correction. And associated with that was greater lumbar curve correction compared to the shorter fusions with less thoracic correction. So, and interestingly, this was not associated with terrible decompensation, which I think has been one of the great concerns about fusing lower than stable. So this is one, again, fused to stable, looks pretty good, but lumbar curve, maybe we could get a little more of. Here's one fused, one below stable, with a pretty big lumbar curve and really nice response to that, that lumbar vertebra. We're going to look at that in a little more detail, because I think this really is, at least in my mind, becoming more clear that fusing one below, particularly if stable is a disc, then going below is better than going above. And what happens at that level, stable is usually also neutral. And by counter rotating around that apical or that neutral vertebra in the transition between the two curves, we really are instrumenting the top vertebra of that lumbar curve. And by doing so, can really move the top of that curve back underneath and rotate that and get the lumbar curve to follow around. I think this is a very powerful method. And if we'll look a little bit more at some of the three-dimensional data, but the zone which has the maximal intersegmental rotation is right here, right at the transition between these two curves. So the axial rotation difference between T11 and T12 in this case, and T10 and T11 are the biggest intersegmental axial rotation deformities that are present. Obviously, the largest axial rotation globally tends to be around the apex, but intersegmentally, it occurs between these curves, and really working to get that segment, all those vertebrae neutral, I think is a really powerful technique. Now, many times we'll see this scenario play out as well. We'll do this, fuse this patient, in this case, even just as stable, and we see this decompensation early. This, I think, makes a lot of people nervous in the beginning, and it still makes me nervous in the beginning as well. When I see it, I don't like it, but it very reliably corrects. There may be some really rare cases where you don't get all the recompensation that you would like, but for the most part, this is going to correct over time, and it's usually just 3 to 6 months as the body starts to get used to this new position. So I don't do anything about it. I don't brace them. I don't do anything. I tell them to maybe stand in the mirror and try to shuck to the right a little bit, but that's all I do. And Bert Gazet has looked at what happens to the lumbar curve in response over the long term. And these two curves end up trying to match over time, and they rebalance well, and the lumbar curve pretty reliably gets close to what the thoracic curve is over time. Well, let's talk a little bit about the 3D analysis of idiopathic scoliosis. I know one of the concepts that I've shared with you all in the past has been this idea that thoracic kyphosis, whether measured as I've depicted here in this image or on a standard X-ray, is really not an accurate representation of truly what's going on segmentally at each of those levels. And if we do a segmental analysis and take these vertebrae just as they were projected in that lateral image before and segment them, but then rotate each of them so that we can look at them directly, we really see that the majority, in fact, in this case, all of the thoracic vertebrae are in some degree of lordosis if you look at it in the local reference plane. That turns out to be, if you stack these vertebrae up, a very large lordotic deformity. And again, if we're going to talk about how we get spontaneous lumbar curve correction, you can just imagine that if you derotate and fix the thoracic curve, but don't address the thoracic kyphosis extent, there's no way for the lumbar curve to derotate into this view as you would see here. It has to stay out of plane to keep global sagittal balance. So if you can restore thoracic kyphosis, I have a very strong belief that that lumbar curve can rotate back underneath and get back into the sagittal plane, and you've got a better shot at getting spontaneous lumbar curve correction. So we know that there's a loss of kyphosis if you measure in 3D based on how big your Cobb angle is, and the bigger the thoracic curve, the more loss of thoracic kyphosis there is typically. You can see there's still quite a range because there's quite a range of thoracic kyphosis normally. But still, when you get to a curve around 60 degrees, there's no thoracic kyphosis left. So you've got to be working hard to restore thoracic kyphosis in that case. We recently looked at a three-dimensional analysis of spontaneous lumbar curve correction using 3D EOS imaging and reconstructions. And we really tried to find out what are the correlates of 3D thoracic correction and spontaneous lumbar curve correction. And this goes to the point that we talked about earlier. We've demonstrated this in the past, that the greater the thoracic curve correction, the greater the spontaneous lumbar curve correction. So again, if you maximize thoracic correction, you can maximize lumbar curve correction spontaneously. I know that makes a lot of people nervous because of that whole decompensation issue, but at least, and again, I think we push this harder when there's a little bit bigger differential between the thoracic and the lumbar, but I still try pretty hard now to get quite a large thoracic correction. The other is that if you minimize the LIV tilt, you get a smaller lumbar curve, residual lumbar curve as well. So there's been a thought that you should leave some tilt to the LIV to accommodate the lumbar curve. But again, the more horizontal you push it, the smaller that lumbar curve ends up. So again, this is sort of another emphasis or another way of saying maximizing that correction of the thoracic will maximize or minimize the residual deformity in the lumbar spine. Now this correlation is not quite as strong, unfortunately, because I've just been trying to sell it to you, but maximizing thoracic kyphosis correction, I think, also plays a role in this. And we can see that there is a correlation. It was, I can't remember what value was, about 0.27 or something. But it does show that if you increase kyphosis in the instrumented segments, you have improved lumbar curve correction as well. So again, looking three-dimensionally, I think we've got to consider all three planes, and derotating the thoracic curve, restoring thoracic kyphosis, and maximizing coronal correction is what's most likely to drive that lumbar curve around. And here's a more modern case. Flexible lumbar spine. So I think this is a reasonable to do. And a 52-46 or whatever that is pattern, I think it's reasonable. The patient's already decompensated to the left. That makes some people think that a selective thoracic fusion would be problematic. And where are we going to go on this? Stable vertebra is way up at T10 or something like that. Please don't go to T10 and try to make this work. Never short of the end vertebra. And I would say in this scenario, we've got to go below the end vertebra. And the end vertebra, the neutral vertebra, are probably the same in this case at T11. So you got to go longer than that. And let's see how this turns out. So we went to 12, one below that end vertebra, derotated completely. And you can see how much that lumbar spine comes around. And in fact, even the decompensation isn't what it was previously. And on the sagittal plane, you can see we've really put some kyphosis back into that area, which again allows that lumbar spine to occupy that space anteriorly with lordosis kind of rotating back into the sagittal plane. So in summary, I think that this really is appropriate for most 1C and 2C curves. It's okay to shoot for maximal coronal, sagittal, and axial correction. There probably are some places where you shouldn't really go all the way, but my tendency has been to get more and more aggressive with time. And I'm now instrumenting all of these at least to stable and typical and commonly one below stable, but certainly never short of the end vertebra. And expect some early decompensation that will improve. And if you counsel the patient on the front end, usually it's not so traumatic when you look like you've been able to predict what's going to happen, and then they'll have some confidence in your prediction that it will get better with time. So that's what I got. Thanks, gang.
Fantastic, Peter. Brand new information, brand new data, a completely new philosophy at looking at this. And thank you for this, because you know, it made all the difference in our thinking, because this is really new stuff. Peter, there are some intuitive questions that come up when you spoke about going into the lumbar curve practically, when you go below the SV and you counter rotate the top of the lumbar curve. How deep do you permit yourself to go? Because it's again going into against the old theory of leaving the lumbar curve alone so that it does its own thing.
Yeah, it's a great question. I would say typically just that one vertebra, one below stable, I think is pretty safe. You know, there's in the old Mark Asher's had some thoughts in the past that you could come down almost to the lumbar apex, which would be just make everybody, at least make me, just crazy to even think that we would stop a fusion at the apex. But so as you're coming down from below stable, you're approaching that lumbar apex. I don't think I would go there, but I must say, as I kind of think about it, I wonder if we shouldn't be instrumenting between the two apical vertebrae and untwisting rather than just twist or going between the end vertebra. So there is something to that, and I do think it's an important concept. The other place that I've actually learned a little bit about being comfortable with being aggressive with this is, we were talking earlier about lumbar tethering. I have a number of patients where I've done a selective thoracic fusion on what I would consider a 3C curve. So the lumbar curve was really not a typical candidate for a selective thoracic fusion, but I did a very aggressive selective thoracic fusion and then used a lumbar tether to enhance that spontaneous lumbar curve correction to try to save fusion of the lumbar spine. So kind of creating a hybrid construct there. And by making a very aggressive correction of that thoracic curve, I realized how much lumbar curve would correct. And I've got some of those cases where I actually didn't even put the tether in because they came around so beautifully by dropping down another level. And some of those cases I went down to L1 even to try to make the tethering segment be a little shorter. So I do think there's something to this. And it may be that, again, if you're doing it in somebody who's still got growth remaining, where a tether might be another option to put onto that lumbar spine to enhance that to come around. Maybe we can try to discover a little bit more in that in that
Sounds like a
population.
great idea to compensate for the residual lumbar curve with a tether later on. We'd love to see your cases once you are ready to show them. There was another follow-up question which echoed from Dr. Chirayu also. You mentioned aggressive correction of the STF segment, but again, we are wary of a difficult lumbar curve which is snobbish and it's not going to move. So is your statement all-encompassing, or does it still depend on the flexibility of the lumbar curve?
Oh, of course it requires flexibility of the lumbar curve for sure. No, I again, I don't know what the absolute magnitude of flexibility should be, but clearly if it's a Lenke 1C or if it's a 1 or 2C curve where it side bends to less than 25 degrees, even if it starts out 50 or 55 degrees, I think you can use this principle again, as long as the thoracic curve is somewhat bigger than the lumbar. And the bigger that difference, the safer this is. I mean, this can work in an 80, 55 degree curve or a 70 thoracic, 50 lumbar, I think fairly reliably. Again, our curves tend to come a little smaller than your curves. So I think you're probably faced with larger, stiffer lumbar curves by the time the patient gets to you. But for those in which you've got a pretty flexible lumbar curve, yeah, I think you can still use this approach.
And I'm just pushing this further. The horizontalization of your LIV also holds true across the board, or once again, you've got to keep one eye on the lumbar curve?
Well, again, I would say that if you would like to push it slightly further than you think the lumbar curve can accommodate, so that you'll actually encourage the lumbar curve to come around. And so I'd be comfortable with a slight amount of wedging below the LIV, knowing that if I don't try, I'll leave a bigger lumbar curve. So I think you can push it a little past and accept a small bit of wedging. If you want to have a parallel disc, you're going to have a larger lumbar curve.
Yeah, what's your take on the L23 disc? What recently they have mentioned about reduction in disc height below LIV or osteophyte formation at L23?
At L23 specifically, L23 for
L12 or wherever we are stopping at the
wherever we stop. Well, I guess, I mean, I don't think I've got any sense that that's been a big issue unless we really disrupt the sagittal plane or make a very, probably the distal junctional kyphosis is the place I've had more trouble in having degeneration at that lumbar segment below. And it's usually because I haven't been able to get enough thoracic kyphosis in and get a little distal junctional kyphosis. That probably seems to be the area where I have the most concern of adjacent segment disease.
Okay.
Awesome talk, Peter. And thanks for taking the time, because it made a big difference. And I think those three strong messages: go aggressively after the thoracic curve, horizontalize the LIV, untwist the top of the lumbar curve, so counter twisting, and get a deep thoracic kyphosis to support your spontaneous lumbar curve. I think we've taken these messages very well, and we'll come back to you with what happens when we try this on our patients.
All right. Good luck. Thanks, Ave. Take care, guys.
And it was a great talk again. Thank you so much.
Appreciate it.
And
Bye-bye.
a follow-up to such a good talk would only be a big speaker from Bombay, and that's Dr. Dalvi. And he's going to talk about big bad deformities, the types that he does the best, strategies of osteotomies and deformity correction. Over to you, my dear friend Samir. Can you unmute yourself?
Okay.
Right.
Yeah. Can you hear me now? Sorry.
Yes.
Yeah. Sorry. Okay. It's a bit late in India, as we all know, and we've had so much of knowledge and so much of information. Even my brain is bursting with all that knowledge, and we're really seeing a lot of new things. But here goes. A lot of this has actually been covered, but let me just, for the record, cover it as well. So basically, the most important thing when you're treating a deformity is to see whether it's flexible or rigid. And if the curve is easily correctable to an acceptable level, all it would need is an instrumentation and fusion. But the problem comes with rigid curves, and what it requires is a release procedure to improve the curve flexibility. That's the crux of it. There is no instrumentation strong enough to overcome the rigidity. What we need to do is make it flexible so that we can then put in our instrumentation. So what is the role of an osteotomy here? A rigid deformity consists of a fixed bony column. So there are many deformities which are really rock solid fixed bony columns. And osteotomy then remains the only way to provide flexibility. You cannot, do a discectomy. You cannot do traction. None of these things work in some cases. And an osteotomy is what gives a circumferential release. You actually get a circumferential release and you disconnect the two bony columns. And after that, you can close a wedge or shorten to achieve correction. So that's in short what an osteotomy does. Now, although this is covered before, I'll go for it. It was first described for ankylosing spondylitis by Smith-Peterson in 1945. And what he did is he did a posterior element resection, and he had the hinge of the osteotomy, or the apex of the osteotomy, was at the anterior longitudinal ligament. And he cracked it open and opened it anteriorly. So this worked well. He actually didn't use, interestingly, instrumentation. It was done in the lateral position. It was done in local anesthesia. And they used to just correct it without any instrumentation. But there was some incidents. So it is not so huge, but there were some incidences of vascular injury and GI injury. That sort of got it into disrepute. This is what it is like. The apex here is at the PLL, but the hinge is at the ALL. So what happens is that when you do this resection and you shorten here, it opens anteriorly. And you can well imagine if there is a calcified or a stuck aorta there, it can rupture. But then we came to a sort of posterior alone surgeries where you have the apex at the ALL. So, with the apex is at the ALL, you do a 3-column resection and you shorten it. So this anterior opening is not a problem anymore. And they have, in order of severity, these. There is the eggshell or the Heinig, the PSO or the pedicle subtraction, and the vertebral wedge resection. So this is the first one, which is the Heinig osteotomy or eggshell procedure. So what he did is he really didn't do an osteotomy. He just went through the pedicle and decancellated the vertebral body. And what he created is a controlled compression fracture and kept it larger posteriorly like this. So he entered both the pedicles. And then when he compressed it, there was a correction. But the next level, those who required more correction, one had to do this pedicle subtraction osteotomy, or a PSO, in which an actual wedge of bone is removed with the posterior elements and the pedicles and an apex at the ALL through the body. And for this, you have to remove the lateral wall as well. And here, the approach may be either transpedicular in many cases, but in the thoracic ones, you can actually go far lateral by doing a costotransversectomy. But if you needed more correction, you had to end up doing vertebral resection. And this was a further advance where more than one vertebra may be excised. So they actually may be more than one vertebra which is excised, or sometimes in things like TB, actually it's a large number of vertebrae which are coalesced into one mass. And here again, the column is shortened. So these posterior closing osteotomies look like this, where you put in screws and you do a wedge. And the wedge actually has its apex at the ALL. And we tend to remove the anterior wedge first and then the posterior wedge. And having done that, the two columns are completely separated. And then you close posteriorly. So this closing posteriorly was safer for the vascular structures, even safer for the cord, except when it became too much. So what happens when it's too much, when it's a really larger magnitude of deformity? Here the column is shortened, but there would be cord buckling, in which case we support the anterior column and use a cage as a hinge. So again, to show you pictorially, this is the osteotomy, posterior, anterior both. And then when you're closing, at this point, your cord has started buckling. And they've shown that cord buckling also can cause irreversible paraplegia. At this stage, what you do is you put a cage in front, which acts as a hinge, and then close it on the cage. So therefore, the overall level of shortening is not as much as it would be if you had completely got the two vertebrae together. Just to mention another osteotomy, though I really, this is a much smaller thing compared to any of these, but since the topic is osteotomy, they are the Ponti osteotomy. So what happens is that in a Ponti osteotomy, you're doing only a posterior osteotomy. What you do is you remove the facets, the interlaminar bone and ligaments, and you then create a chevron, which is forcibly closed posteriorly. This is not the same as a Smith-Peterson osteotomy because there is no anterior opening which is done. Here we depend on the flexibility of the discs to get correction. So you create a chevron like this, and then you forcibly close it posteriorly, which opens at the disc. It does not open through the vertebrae. It does not cause an anterior opening. So to sort of classify this, Schwab et al. In 2014 put them into 6 grades, where the first one is the simplest, where you just do a partial facet resection. So this will give you a very small degrees, maybe 4 to 5 degrees of correction. The Schwab 2 is a complete facet resection, which is really the Ponte osteotomy, where you remove the entire facet along with the posterior sort of interspinous ligaments, etc. A Schwab 3 is what we call as the PSO, where it's the pedicle and the partial vertebral body. Whereas a Schwab 4 is also a PSO, but you also include the upper disc. When you do that, you get a larger wedge, as you can see in the shaded area. Schwab 5, what you do is you are removing one whole vertebra and one pedicle and the adjacent disc. So this gives you much more. So this diagram is not correct. It's from Schwab's own paper, but it's not correct because we would be doing this in a kyphotic spine, not in a straight spine. And finally, the Schwab 6 is a more than one vertebra which is removed along with the vertebral body and the disc. So this would be a Schwab, which I think at least the PG students need to know. So when do I actually do an osteotomy? It is done in rigid deformity. That's very important. You just don't, it's a major procedure. You just don't select it without reason. So healed TB, very badly neglected scoliosis, or bony deformity, where it's a congenital or an osteogenic deformity. There's nothing you can do if you want to correct a hemivertebra or a bar. And of course, it's more useful in angular deformities, because if you use it in round deformities, then one osteotomy may not be enough. A few cases, just in the order. So this is a fracture which is healed in kyphosis, and you do a wedge like this because there's no way else that you can correct this. And this was with a very short fixation, we were able to get this correction. That's another one with a very small osteotomy. This is a decancellation osteotomy. Coming to this, which is a larger post-TB deformity, here we've done a vertebral wedge resection. One vertebra was resected and a posterior closing was done. And so these cases have been done from 86 to 90. This is way before any of these papers really came up. That's another one. This was a PSO. And you can see these sort of deformities. These are the dangerous ones. You typically see them in TB, where you have the apex of the internal gibbus pressing on the cord. And after correction, you are able to get a round back correction and a much more cleaner shape. And these deformities, again, seen only in TB, where the whole thing is a coalesced mask. You really can't name this. You basically go from the sides, remove as much as you can, separate the two columns and put an implant and get correction. Another post-TB kyphosis. Again, sharp angular kyphosis corrected with a pedicle subtraction or a sort of wedge resection. This is like nearly a Schwab 6 osteotomy, which in those days we didn't know what it was called. And even in small children with the sharp apices, we do this kind of. Sometimes we have to put a block or a graft in front, as was seen in that case. And this is a osteogenic or a congenital kyphosis, where again, there's nothing which is going to work except an osteotomy. You have to separate the two bony columns. In revision cases, again, where it's partially fused and the implants are broken, you have to do osteotomies because a partially fused mass has to be broken or osteotomized circumferentially to get a correction. So this is one where we use the multiple different types of osteotomies because we've used some pontes at the upper end. This is another round back sort of Schurman kind of deformity, where we used sort of an osteotomy over here, like a pedicle subtraction, but higher up to get the shape, we used multiple pontes. Of course, scoliosis as well, congenital scoliosis, where there is actually a hemivertebra, we need to use osteotomy to get the proper wedges out. And something like this, which is very rigid, not getting corrected by any other way, we have to use osteotomies separate. As you can see, the two columns are separated and then corrected. Again, severe rotated scoliosis. So for these, the planning becomes very difficult, and a lot of it, honestly, I don't know about navigation, 3D, etc. But in our time, when we did these surgeries, we did it with a 3D understanding and the sort of feel, where we put in the implants by feel, and we did the osteotomies by a sort of feel, and we did circumferential osteotomies and corrected them. So even the kyphotic element was corrected. So this is the last case I'm showing because we are running really short of time. So I cut my talk down. Although it's already been shown by Shankar, but this is how an ankylosing spondylitis, which is an ankylosing spondylitis is a classic case where you need to do an osteotomy. And this, this is how we planned the osteotomy. This is how much we are supposed to get. And we saw as to what sort of corrections we'd get with a traditional PSO or a pedicle with disc PSO. But what I do is this technique, which again, I've been doing for a long time, but somebody has recently described it as a corner osteotomy, where we open a little anteriorly, but don't have the apex right in front. You have the apex somewhere in the middle. And, we know all of this already, putting the implant. And that's how I do the osteotomy. See, the osteotomy is not going all the way to the front. The disc is removed and a corner of the vertebra is removed. And that's the final result. And that's how it is. It opens. Now, the question is, because you can't do this in anything except ankylosing. In ankylosing, this is going to fully heal up. And as you can see, we got the balance and healed up. And we've got like more than a 5-year follow-up on this sort of guy. So you can see that although it was only at one level, we got 47 degrees of correction over there. And I didn't have to do more. So my own series, which is not relevant for this talk. I've also skipped the literature part again, because we are running short in time. And it was just this is just generally to give an overview. But some tips and trips, what have we learned really? So you have to have segmental fixation and your screws must go in first. There is no way. You must have very good, safe screws in before you do anything. Don't try to put the screws afterwards. Don't go too short. We made these mistakes. If you see some of my x-rays, some of my slides, as I said, many of them were done very early, 95, 97, 98, 99, at that era when people are not really doing this. And we did do some very short fixations in those days, but now we know it's better to go slightly longer. We have to use a temporary rod because once you do the osteotomy, all hell breaks loose. The columns separate. Sometimes there's a translation and you need to use temporary rods. We use different contoured rods of different contours to slowly correct it. We start the osteotomy without opening the canal. So many of the descriptions, they do a laminectomy first. But my teacher, Dr. Lahiri, is very strict about this, and I do the same, that we do most of the work without opening the canal for two reasons. One, we don't want to see the cord, so to let an instrument go in. And secondly, if the epidural bleeding starts, it becomes a mess. And if you have CSF, then you lose all kind of you lose your cool. So we do as much as possible from outside first and see the cord last. You have to undercut the laminae and do a very good posterior decompression before the wedge closer, because the laminae cutting into the cord is a cause of deficit. And you have to have a very, very slow controlled wedge closer, because translation is a huge problem, and cord impingement and buckling. So your closure phase becomes very, very critical. That's that's your entire surgery rests on that phase of closing it. And the translation is sometimes very difficult to control. So you need to have very good implants, screws, basically the external fixator principle, some screws very close and some screws very far. And then you really need to control this with sort of rods. And we also use these long-eared reduction screws and try and do it as slowly as possible. And the minute you see the cord buckling, you just put anterior support and try and avoid that. And you must confirm that there is adequate anterior column contact or cage, and after that pack it with bone graft. Because if you don't do that and it doesn't unite anteriorly, then your whole deformity is going to go again in 3 to 6 months. So finally, an osteotomy is required for effective correction of rigid deformity. If you're going to treat rigid deformity, you need to know how to do osteotomies. And angular deformity requires a single osteotomy. And the multiple osteotomies are very stressful. I mean, I'm not, one can do them, but it's very stressful. Closing wedge osteotomies are safer, and that's what we're doing now. And if you have multi-apical deformities, especially if the discs are mobile, then you can do Ponti's osteotomies. And each one may give you 5 degrees of correction. But then if you've done like 7 or 8, then you get that many degrees of correction. Most important is risk versus reward surgery, and this is something which you as a surgeon need to know, and the patient needs to know absolutely. I mean, you have to discuss with him till he's blue in the face. But it is risk versus reward. There is no way that you can say, come, let's do an osteotomy and go home. Everything may go right in most of your cases, but if something goes wrong, then all hell breaks loose. And if you get a paraplegic or a death or a vascular injury or all those things, you'll really be sort of upset. So I think, given the time constraints, that's as much as I can talk. And I'll stop my screen share now and hand it over back to the organizers.
Great talk, superb execution, and a lot of learning tips from last 2 to 3 decades, Dr. Dalvi. I would like to ask you how much risk when you do this kind of deformity. You talk to the patient that this much is the chance of worsening neurology in these cases.
So I think, see, those who, first let me give you a scientific answer and then the practical answer. The scientific answer is that those patients who already have neurological compromise, they are definitely more at risk. And I'm very worried about doing osteotomies on patients who even have exaggerated reflexes. But if they have spasticity and if they actually have deficit, I really worry. And those are the patients I consent the most. And I sometimes sit and think, like, for instance, if there's a patient who's like 40, 45 years old and who's come with a late onset paraplegia because of an angular kyphosis, I may actually say that let's just do an anterior decompression and, you know, forget about your deformity. Let's think about your neurology. So those who are already neurologically involved are the ones which are the worst. Intra-op, if you control your blood pressure and all of that, and we do tend to use neuromonitoring, then that's fine. But if you ask me, how do I counsel the patient? I tell the patient that overall, the chances are 1 to 2% of you getting a deficit, but that does not matter. It doesn't matter. I tell the patient, for you, it is either 0% or 100%, which means at the end of the surgery, you wake up paraplegic, in which case it is 100%, and you don't care about the 98 others who didn't get it. And at the end of the surgery, if you wake up and all is well, then it's 0%, and, you know, the others can again go to hell. So it's very important for the patient to understand that for one patient, it is 0% or 100%.
Okay. I just want to ask one question where you are talking about doing posterior laminectomy. In severe angular kyphosis, whether you prefer to do posterior complete decompression, or you prefer to do sham rod and going from. Okay.
So I would go. So depending on so there are two ways you can do the anterior job. One is a trans pedicular, what you used to do. So we just go through the pedicle. We use curettes, burrs, etc., and start with a sort of an eggshell, and then go on increasing and increasing and increasing and increasing the eggshell. Finally, taking on the lateral walls, which can bleed, and then the laminectomy. And the last thing which we remove is the posterior vertebral wall. The wall of the posterior is the last thing we remove. That's the last thing which we make it into a thin sort of paper thin thing, and put in a dura and break it down. You know, just break it down away from the cord. And if it's a very severe thoracic, then I actually do bilateral costotransversectomies, 2, 3, 4 sometimes costotransversectomies, and then go all the way around the cord, drop everything down, and we actually have the whole thing looking like this, you know, and we can go all around it. You can actually put a finger, you can look at each other through it, and then do the osteotomy.
Great learning tips, Dr. Dalvi, and I'm sure every one of us who look forward for doing this kind of deformity, all these things, and it's a learning curve always when we think about doing these kind of complex cases. Thank you for this, and we'll have to
Thank you, Shailesh, and I'd like you to see my hair and your hair, and this is because of doing all the osteotomies. So think about whether you want to really start doing them.
Thank you. Thank you. We'll go to the next speaker, Dr. Vishal Peshettiwar, for the minimal invasive surgery and deformity correction in lumbosacral high-grade spondylolisthesis. Over to you, Vishal.
Hi.
Yes, as everyone is talking about minimally invasive surgery and how to correct it, deformity correction and high-grade listhesis, it's a challenging thing. Open surgery, we all are aware of things and different techniques, but MIS reductions are quite challenging, and that's where Dr. Vishal, who is doing a lot of MIS work in Mumbai, will be sharing his thoughts and his experience today with us.
Yeah, can you see my screen now?
Yeah, we can, but yeah, perfect.
Okay. Hi, I'll make this brief. I thought I would have a 13-minute talk, but we don't obviously have the time for this. Hi, good evening to those in India, and I think good morning to the rest. To understand what is the minimal access spine surgery, I'm just going to go through a basic video. Instability like that, you want to do minimal access fusion. Basic fusion, mark the levels, put in your tube retractor after dilatation, check, and that's what you see. That's the facet joint, that's the pars there. And this is a 13-year-old video where we would use landmarks to put in our solid screws on one side so that there would be some money that could be saved. At the end, I prefer to use a chisel. You can use a kerosene rounder or a Leskel to open this up. So to orient, that's the superior end, that's the inferior end, that's the medial, and that's the lateral. And those waxed holes are the ones through which the screws would be put later. That's the ligamentum flavum that comes out. Take some of the lateral aspect of the lamina so that you get some bone graft. That's the dural sac there, and that's the disc. In a low-grade listhesis or a degenerative spine, you should be able to see this as clear as that. The most important part of a fusion is this. It's not the speed, but it's the thoroughness in which you prepare your end plates. That's you have to go to the opposite side, scrape the opposite side, take a PLL's, rather a posterior annulus scraper, make enough space for the graft so that nothing pops out and hits the dural sac on the other side. That's the PLL scraper. Then I don't use a rasp anymore, but in those days we used to rasp to open up the bleeding edges. Then again, I don't do the wash again. Use a box chisel. This is something I always do. This ensures that you have an adequate size cage going in. And then once your size is checked, you put in your cage. Put in your bone graft and you put in your cage. Funnel to put in the bone graft. And I prefer a peak bullet cage to go in. Bayoneted instruments help you to keep your line of vision very, very straight. And that's the cage which you would put in. Cage going in. And that's the position of the cage. I'm going to quit this video now and go to the next one. And that's what you would expect: restoration of the lordosis, restoration of the height, and a secure fixation. Well, now coming to the high grade listhesis. This is a grade 3 listhesis. Most of this, when you, especially in adults, are not going to be rigid ones. These are the ones, this is on the operation table, whereas this is what we got in the outpatient. This is a lytic listhesis. These are most likely to be mobile and reduced by a degree on table. These are nearly as good as doing a simple grade 1 listhesis. That's a video of grade 3, which was reducible to grade 2. You need to open up a little more wider. That's medial, that's superior, that's inferior, and that's my side. I'm using a 15 number blade to go in. Most of these are at the L5 S1 junction. You need to take out the S1 posterior angle there, and then you go in with your puka, just making space there. And these are fairly mobile, so they allow you to go in. But one precaution, you should be using more blunt pukas rather than sharp ones as you escalate the intradiscal puka work. So I prefer this. These are Medtronic pukas that are available with the set that they go in. This prevent end plate damage because majority of these people are going to be osteoporotic. Now, this is the set I've got made locally for us. This starts at 6 millimeters and goes up to 16 millimeters. This paddle shifters are blunt. So the whole concept of having this paddle shifter is we have a very finite length of the annulus and the ligaments that hold two vertebrae together. In a listhesis, as you have a slip, they crumple up. And this crumpling, you put in your paddle shifter, rotate it, and bring it back to its restore the height by stretching the soft tissues. And you cannot stretch a healthy, how to say, an annulus beyond a certain point. Of course, in a very badly degenerated ones, it's going to tear. But the higher you jack up the disc space, easier it gets to reduce. That's my principle of how we. So we use serial dilatation. Of course, this is only after a near complete discectomy. You can see the positions of all these paddle shifters is right bang anterior to the L5. In a listhesis, the S1 is always going to be more towards you than the L5 edge. So you got to remove all the disc right up to this edge and then use serially large paddle shifters to restore. And as you see, as we put in larger devices, the reduction gets better. So this is a redo case. There was a laminectomy done a decade plus back. And this is the clinical post-op X-ray that you can see. I mean, if you get a rigid one, something like this, a rigid listhesis is something that should not be attempted very early into practice. You need to have a complete armamentum of curettes of all sizes, of ultra cuts from small to large so that you can open up this space effectively. This is some of the curettes that we use in all sizes. A lot of them are bayonet to keep our line of vision clear. This to orient, that's the medial, that's the superior, that's the inferior, and that's the lateral. This is a 30, it's a 22 millimeter Thompson retractor we are using. So I'm just taking out the facet here. We've already removed the superior facet of S1 to a large degree. That's a 15 number blade trying to make a entry into the this space. This is a Penfield, a number 4 Penfield that cannot go in. This is an extremely rigid deformity, and I would request all the viewers not to go in with this as your first case. I'm using a number 3 over cervical curette to open up. This is a 2 millimeter kerosene rounder, 1 millimeter actually kerosene. I made a small entry there. This is still not good enough for that Penfield to go. At this stage, this is a osteotome, a very thin 10 millimeter wide osteotome that I'm just using to open up, and this puka that's going in is 6 millimeters this way. This way is 3 millimeters. So this puka just can't be opened up. It is not wise to be rough at this stage. This is obviously very rigid. You need to go back, use progressively increasing sizes of curettes to open up. I'm not showing how the curette has been used, but it's like you would prepare a disc, but it takes longer time. You have to make a small area, take out the disc, then go in again. This takes about an hour sometimes. Again, try if you can gently open up. Once it has been opened up, so that's the 6 millimeter height we have gained. Once this height has been gained, you leave it there for 5 minutes, let the soft tissue stretch. Then again, use this bayonet curettes to reach to the deeper areas, and then go to the opposite side. This angulated curettes then be used to curette the opposite side. This gives you some more space. It opens up this space. If this is not working, then you put in a tube on the opposite side and take the facet out on the opposite side and do the release again from the opposite side. Then put in this pukas and open it up. So that is what we got after nearly 3.5 hours of surgery. That's our 1 month down the line. It's very gratifying. You need not go in to get an S2 iliac screw if you're doing a proper S1. I have never gone to 4, and so far that we are doing it for nearly 7 years, we haven't had a problem. One of the tricks is remember that L5 S1, where 90% of your work is going to be for high grade listhesis, is always going to be at an angle. So your table has to be head up. So this white mark here is how the angulation of the disc is going to be. So your vision is going to be at an angle if you're keeping the patient flat. So one of the things you have to remember is to get an head high, so the orientation becomes more at a right angle to the floor, and you can work in a straight line, which is better. So that helps. Use navigation. If we routinely use navigation to get this tricortical hold. Now I've started going a little bit lower, but see in this patient, you can see this is an O-arm cut. This is absolutely osteoporotic. It's only this tip which is sclerotic and has any purchase. So unless I go through this tip and get my screw to bite at this area, it is never going to give you good hold. And if you don't have a bicortical hold here, it is going to fail. There is no shortcut in this surgery. It has to be done properly. If you don't have an O-arm, what we used to do before we got O-arm was to take in Lenke, go right up to the opposite cortex, bang it through, check it on a C-arm, put in a feeler, ballpoint feeler, and check that it's actually gone through and through, take a measure, and only then put in our screws. These are some small steps, but this will help you. You can use the screws to reduce, but this is only after you have done a complete discectomy. This is the L5, and that's the S1 screw outside. Moment the rod is engaged, what I do is I tighten the S1 a little bit, let it drop down, and then tighten the L5. So this gradually pulls up the L5 screw. But for this, you have to have a release disc. If it's a stiff construct and you try to do this, the screw is going to walk out. So these are some of our cases, a fairly rigid and stubborn deformity with osteophytes all over, with gradual distraction, and then further jacking it up by using an expandable cage. Another of this expandable cages, this one is from Medtronics, but the beautiful ones that have come from Zimmer and other local companies too. This is a high-grade listhesis in a grossly obese patient. In doing an open surgery in such kind of patients is messy. This is done about 7 years back. These are the CT scans that we did to see if there is union, and there's actually a trabecular pattern that has gone through and through. These are some of the rare 2-level high-grade listhesis that we have done. This is about 2.5 years old. We published a few of our cases. This was in 2018 Global Spine Congress in Toronto. That time we had 12 cases with 2 years of follow-up. Now this is currently our statistics is at 24 cases that have been followed up to union with a CT scan at 6 months, and now these are finished a 2-year follow-up, and those are the statistics for those who are statistically inclined. So far, we've managed to give all of our patients a sound grade 1 Bridwell fusion, as my fellow likes to remind me. Those are some of the CT scan images after 6 months of the surgery. Thank you.
Great talk, Vishal. Very, very crisp and absolutely on the ball. And you've shown some really stellar work. You've really dived deep into this business of minimally invasive deformity correction in a way, isn't it? High grades, we're not so much aware that you're doing such high grade. Any tips for dysplastic high grades?
So we haven't unfortunately done any one of them so far. So, but I guess as long as you adhere to the principles, it's going to be okay.
And I think with this OARM, those smaller pedicles, etc., will be a walkthrough for you.
Basic issue with the dysplastic is going to be getting a good screw purchase. So now, as we have the OARM, if you see, I'm using a separate entry point, which is about 6 to 7 centimeters lateral to the midline. Whereas before we used to put it through the holes on the side of the TLIF, through the TLIF incision itself. So this lateral entry, actually you get a bite at the lateral end aspect of the pedicle. So in a dysplastic, I think that works more. I haven't, to be very honest, done a single one of high grade. It's there. I believe they're going to be very, very difficult to do. Then most of these old people come to you when they have an acute lysis, when the disc is completely gone and they get a high grade. These are mostly reducible. So 80% of these, which look like grade 3 and 4, when you put them on the table, oh, they're grade 2 or grade 1. There are 20 which wouldn't budge. These are the ones you need to worry, because they don't have the strength for the screws to get the reduction done. So a lot of people would put a 4 and put an S1 and then get the L5 out. And I had seen a couple of them with my boss, and the L5 used to walk out, and we had the same thing going. And then you are praying in between the fight between the union and the implant backing out. So here, what you're doing is you're releasing the disc, you're restoring the anatomy, you're restoring the discal height. And then the fusion comes in. Another thing we use in these cases is we're using a lot of, it's an off-label use of teriparatide. But somehow all the people in whom we've used teriparatide, the fusion has been seen much earlier than in those in whom we haven't used teriparatide. So we have about half of them with and half of them without, for whatever reasons we couldn't start teriparatide. And the ones that took teriparatide had a better union and had a faster union than the ones that did not.
Lovely.
Of course,
Pearls of wisdom from the fastest growing spine factory in Bombay. Mark my words, Vishal is going to be the next Bhojraj, if you may. Thank you, Vishal. That was lovely. And don't yet get into your pajamas, because we have the big boss from Delhi. And once again, leading the millennial brigade is our own Bhauk Garg, who's been making waves in spine literature as well as spine work. And it's a trademark signature opening slide that's already up there, Bhauk. Maybe you could finish your lovely talk with a couple of jokes also. It's all yours.
Thank you, Dr. Abe, and thank you, Salish, for giving me this opportunity. I will try to finish within 10 minutes. So we know that the congenital scoliosis can occur because of either the failure of formation, which can manifest in the form of the hemivertebrae or the wedge vertebrae. It can be because of the failure of segmentation, so it can produce both coronal as well as the sagittal deformities, and they could be in the form of usually a bar. And then there comes the mixed deformities when there are both hemivertebrae and there is a bar. So these are the most complex deformities and which grow very fast. So this was the classical paper by Winter. In that they studied the natural history of congenital scoliosis, and they found that the progression patterns they are quite unpredictable, and they, like idiopathic curves, maximum growth occur during the adolescent growth spurt. However, failure to recognize a subtle but relentless progression during early childhood is the most common error. So early identification of those curves is the maximum, and the goal of treatment remains the same as with any other scoliosis, that to prevent the deformity and to achieve the physiological alignment with as short as fusion as possible. So one has to identify the high risk curves early. You have to recognize the subtle progression, and you have to intervene early before the secondary changes develop in adjacent normal vertebra, what we call as the compensatory curves. And always rule out the associated cord anomalies, CNS anomalies, and we routinely get the echo as well as the abdominal ultrasound to rule out the kidney abnormalities in these patients. Decision making for hemivertebrate depends upon basically four factors: the morphology, the location, the growth potential, and the balance. Morphology, we know that it depends upon the segmentation of that particular vertebrae. Location wise, the thoracolumbar and the lumbosacral, they are the most ominous ones, and one has to also see whether these hemivertebrae are at the apex or at the end of the curve. Growth potential is very important to see that what is the age of the child. You have to document the progression of the radiographs, and you have to look at the morphology of the hemivertebra, whether they are inside or outside the curves. And one has to also take care of the balance of the shoulder, the pelvis, the coronal, as well as the sagittal imbalance. So sagittal imbalance and kyphosis remains the most important factor when you decide your treatment of choice in these deformities. So Roof et al., they described the posterior hemivertebral resection with transpedicular instrumentation. So, and they also pointed out that the compensatory curves, even if they are there, they can also correct with short fusion if you intervene early. So like this is an example of a hemivertebra, and this has been done with the posterior approach with a short fusion. The everything has been controlled. This is an example of another hemivertebra, and you can see that the compensatory curves over a period of time, they also correct with growth. And even the sagittal malalignment, it also improves with the growth if you are just operating these hemivertebra at the right age. Lumbosacral hemivertebrae, they deserves a special mention because they produce a oblique takeoff, and then they produce the grotesque deformities. So if you intervene early, you can achieve a good coronal and the sagittal imbalance. If there are multiple hemivertebrae or the complex anomalies, then you require either growth-friendly constructs if the age is if less than 10 years or 11 years, and if it is an older child, then you need the definitive treatment. And then in the early onset, we can either use the growth rods, or now we use more and more the magnetic growth rods. Like this is a complex deformity, and you can see that a good alignment, sagittal as well as the coronal alignment, has been achieved with these growth rods. And sometimes if there is significant pelvic obliquity, you have to go to the pelvis for your lower anchors. And again, you can achieve a good outcome with these growth-friendly techniques. People have seen the differences between the TG traditional growth rod and the magnetic control growth rod. Whereas the planned surgeries, they are very less with the MCGR because you do it on the OPD basis. The unplanned complications, the unplanned return to the operating theaters, they remain the same with both the groups. This is a very significant deformity you can see here. Now we are using more and more the active apex control technique, in which we use a smaller diameter rod which can slide in between the domino, and we use the short apex fusion. So it's a modification of Schiller technique, but it doesn't require the frequent return to the theater, because with growth these rods, they slide actually into that domino. We call it as active apex control. And now more and more we are using these techniques. On one side we are using on the concave side we are using the magnetic rod, and on the other side we are using the APC technique on the convex side. So basically we are distracting the magnetic rod on the concave side, and the convex rod, it slides automatically without any repeated surgeries. This is a case of multiple hemivertebra. You can see there are multiple hemivertebrae in this 13-year-old female. And there is a lumbosacral hemivertebra as well, which is producing a significant lumbosacral kyphosis if you see in the sagittal. And this is the clinical pics. You can see the shoulder imbalance, and these are the CT scans. You can look at all the vertebra. So you have to take care of the the secondary changes in the vertebrae which have developed over a period of time. And when you correct these curves, you have to correct only that much, which also takes care into account of these secondary changes. Otherwise, there will be an off-balance curve to the one side. So in this, we chose the L5 vertebra, hemivertebra excision, because we wanted to completely take out the oblique takeoff, and we just did the in situ fusion of the D11 hemivertebra because there was no kyphosis there, and the D8 hemivertebra we just did decancellation to balance it along with the rest of the curvature, and we could achieve a good clinical and the radiological outcome. One important point is that sometimes, especially in these curves, the entry point of the pedicle is actually below the upper vertebra. It is hidden. You cannot see it, this thing. So we use a tall clip on the lower or the upper vertebra, and we just pull it up so that that entry point is visible, and then we put our screws into that through that entry point. And the other technique is that you can use the screw handle on that screw which you have already put, and you can lift the vertebra with that screw, and then you can see the entry point, and there you can inject. And there is significant rotation deformities can occur, so one has to be very careful. And you can see that it seems that the screw we are putting into the canal, but actually we are going into this thing. And it also shows that how much tilted is the vertebra in the sagittal plane. And we have also published the role of 3D printing in these patients in these deformities. And 3D printed, if you have the facility of this thing, it is also a good technique to put screws in this thing. If you delay these surgeries at an early stage, then they manifest as very severe grotesque deformities later on, and that means that you will have to deal with a larger and a stiffer curve with severe secondary changes in the normal vertebrae. They require more invasive surgeries in the form of more severe osteotomies, which mean greater blood loss in the surgical duration, and there's a greater neurological risk, and you require a longer fusion. For these sort of deformities, for very severe deformities, we have described our own modified posterior vertebral column resection. So what we do, we actually preserve the posterior elements and the medial half of the lamina till the end of the procedure while we complete the whole of the vertebral column resection. And you can see that the cord, after even doing the whole of this thing, the cord is perfectly pulsating. And I'm sure the people who are doing routine PVCR, they must have not seen so much healthy cord after doing the VCR in such severe deformities, because the cord keeps hanging from the epidural veins from the posterior this thing, and there is minimal handling of the cord. And the posterior wall resection, when you're doing, the cord is not falling on the posterior vertebral wall while you are taking out the posterior vertebral wall. And we could achieve a good correction in these sort of deformities. Since when we have started doing these sort of osteotomies, we have not seen any permanent neurological deficit in any of our patients. You can see that the good correction which you could achieve with this technique. A special mention about the neglected lumbosacral deformities, and they can be very complex, and they require the iliosacral fixation, and sometimes you have to use a separate correction for these severe coronal imbalance to get an optimal coronal balance. And sometimes we also use multiple rods and to get the optimal sagittal balance, and you can see here we could get the very good outcome. And like this case, this was a very severe lumbosacral deformity, and you can see that the sacroiliac joint is dislocated here. So there was no point of getting adequate purchase. So in this case, we had to use the two S2 iliac screws to get the optimum purchase for doing VCR at the lumbosacral junctions. And these junctional regions, when you do VCR, they require special vascular and the neurological considerations when you are doing, and one has to be very careful. Another junctional area is the cervicothoracic region, and you can see that these are very severe deformities, and there is a often associated with the spondyl deformity as well. And if you could see here that you see that there is a significant costopelvic impingement in this child, and the scapula is almost touching the mandible. And you can see also that because of the spindle shoulder, patient was in severe pain. And you can see that there was a prior neurosurgical procedures being done, so there was a lot of scarring in this patient as well. And you can see that there was some sort of cord changes as well, and there was a spina this thing also. So we did a careful planning. We also get we have to put the cervical pedicular screws in this thing, because to control the cervical lateral mass screws will not work. So one has to put and we have published the safety and feasibility and our own techniques, especially in pediatrics of axial cervical spine without navigation. And this could be very challenging, but if you opt the proper technique, then they become very useful asset. And we could get a very good correction with the help of the VCR and the cervical pedicular screws in this child. And you could see that the overall And I also added the modified Woodward procedure in this patient to get these scapula down. And you could see the correction power that the whole incision has shifted to the other side. And we could get very good achievement of the coronal and the sagittal balance in this child. If you see the multiple deformities, multiple apex in these kyphotic in this congenital scoliosis, then you have to specially pay the attention to the kyphosis. And in terms of Boachi, you call as the alpha deformities when there is a horizontal segment between the two apex, and treating them, they require again very severe osteotomies. And I only do osteotomy in these patients only at the kyphotic spine, and I just do the posterior column osteotomies at the other sort of congenital deformities in these sort of cases, and we could achieve a good outcome with both coronal and the sagittal balance. Sometimes you also get these complex cases when as a complication of growth rods. You can see here that the growth rod was applied, but now the spine is toppled over as well as the below the growth rod. So again, one has to take very carefully this thing, and there was a very significant coronal as well as the sagittal imbalance. And when we opened it, there was a significant the whole of the spine was autofused, which is a known complication of growth rod. So we just did the posterior column osteotomies above and below this autofused segment, and we could get very good sagittal and the coronal balance in this child with very good clinical outcome. This is another case in which the Shilla technique was done, and then this child decompensated, and she presented to us with such a severe deformity, and what we call it as a lowering of apex because of the crankshafting phenomena. So these curves, they become very severe, and these are very much scarred when you opened up because of the repeated surgeries, and then they require the vertebral column resection at the apex, new apex, and then frequently you have to go to the pelvis, and you can see a significant correction in the pelvic obliquity as well as the overall sagittal and the coronal profile. These patients, they also, because they undergo very significant and the significant number of multiple surgeries to get the vertebral column resection at the apex, and then you go to the pelvis in these patients. We have also analyzed their coagulation profile and the metabolic profile as compared to the AIS patients. We could find that these patients, they have poor bone mineral density and high bone turnover. So sometimes you have to be very careful that your screw purchase is good, and you have to be very careful about your multiple anchors should be used to get the good purchase in this thing. So the take-home points are that decision making in congenital scoliosis depends upon the morphology of the problem, the location, the growth potential, and the overall balance. In high-risk cases, you should intervene early. You have to pay special attention to the kyphosis, and growth-friendly implants, they may not be so friendly in the end. Thank you.
Great talk, Bauk, and excellent execution of very challenging and complex cases. Looking at it, Siddharth, would you like to say something?
No, really challenging cases. I think congenital deformity are, in terms of pediatrics or early onset scoliosis, they're really challenging. And I think some of the cases that Dr. Bhavuk has presented and the kind of results he's gotten, I mean, really kudos to him. It was great having you here, sir, and it was fantastic looking at some of those cases you presented.
Chirayu, any comments?
I think that was an excellent talk, Babak. I think congenital scoliosis, I think every case you need to plan it. You cannot have a general rule. So you really need to plan it right from and then you need to make a long-term plan. And it's not just one surgery you're going to do and end it. And I think it's very good to have an interaction with your colleagues who have more experience whenever you plan a congenital case. It's not like doing an AIS. So I would definitely be making a team kind of thing. And it was excellent combination of all aspects of congenital scoliosis. Yeah, nice.
Yeah, a lot of time
and you really need to do things out of the box when you're doing congenital. It's not like doing AIS or anything else.
Completely agree, Chirayu. A lot of time there are multi-level fusion masses and things like that. And it's a nightmare at times, and every case is different. It is not, nothing is planned in congenital. So you have to take
absolutely
of salt. Yes, Surya Prakash.
The most common
It's been a great talk and we really enjoyed the session. Thank you, Sailesh, for giving us such a great opportunity, a great learning. And I think all good things really have to come to an end at some stage. though we have overshoot more than an hour.
Yeah, I understand we really overshoot today, but I thank you all the faculty for giving great time today. And this was the
Thanks, thanks, Sailesh. Thanks for. I think Bhavuk's talk was fantastic, and it was really mind-boggling. I don't think I can ever do such surgeries. It is great. So I think every talk right from beginning to end was fantastic, and I learned a lot. And thank Abhay for taking us through this 4 hours. I find that I get to sit 4 hours because I never otherwise sit 4 hours in a chair.
Very true.
Yeah,
Vishal, that was a very good talk of yours as well, and
yeah,
it encourages us to become young at an old age. So, as Abhay says, keep trying.
Thank you everyone from all India and abroad. Thank you everyone for being there and looking forward for future interactions and meetings. Thank you and wish you a happy Diwali and stay safe, stay healthy. Thank you all.
Thanks. Bye. Good night.
Thank you.
Bye.
Bye. Hi Ashok.
Yeah, people were waiting.
Ashok.
People have disappeared within seconds.
Are we offline? Ashok?
Hello?
Yeah, Pramod, just check Ashok is around.
I'm here, sir.
Yeah. Are we done?